I'm one of the organizers, and it's a great pleasure to honor to introduce our moderator, also our program chair, Dr. Colin Brennan. Colin is an entrepreneur, is a biomedical engineer. I think he's also one of our premier volunteers. He's the vice president for technical activities. It's a great honor and pleasure to working with him for many years. Colin, podium is yours. Thank you so much.
Thank you, Metin, and welcome to our speakers for this second symposium of the IEEE EMBS Grand Challenges Forum on COVID-19. Today, the focus of our talks will be on screening and diagnostics, and it's broad as to how we can approach this as a community and what is actually happening and being put in place relative to rapid testing. As everyone knows, that the COVID-19 pandemic is accelerating with 53 million infected and 1.2 million deaths globally, and 10 million infected and 240,000 deaths reported in the US as of today. So as we've identified, critical to bringing the pandemic under control will be the widespread deployment and utilization of rapid diagnostic testing, integrated with contact tracing and isolation in combination with therapeutic interventions. So today, you'll hear from 8 experts on progress in rapid COVID-19 screening and deployment. And our first speaker today is Dr. Nancy Gagliano. We're very fortunate to have Dr. Gagliano in that she's currently leading the large-scale deployment core in support of the NIH Rapid Acceleration of Diagnostics Program for COVID-19 testing, otherwise known as RADDX. Previously, she was Senior Vice President and Chief Medical Officer for the CVS Health Minute Clinic for over 6 years. In this capacity, Dr. Gagliano oversaw the quality of care, point of care testing, and growth expansion of the over 1,000 clinics that sees over 6 million patients annually. Previously, she spent 21 years at the Massachusetts General Hospital as a Harvard faculty primary care provider, and ultimately the Senior Vice President of Practice Improvement. Dr. Gagliano received her MD from Harvard Medical School and her MBA from Northeastern University. So very fortunate to have her today, and Dr. Gagliano's talk will be challenges in implementing COVID-19 screening. So Dr. Gagliano, the floor is yours.
Thank you, Colin, and thank you all for inviting me today. And as you were all joining, we were talking about the fact that we would prefer to be having this conference in Italy right now, but that might have to wait another year. So I'm delighted to be here. I'm honored to be here. I'm representing RADDX, which is an organization funded by the NIH to select high quality potential diagnostic tests and get them into the market as quickly as possible. And RADDX will be having a presentation about RADDX itself a little bit later this morning. But today I wanted to share with you some insights about the complexities related to screening. I think we've all seen lots of conversations about diagnostic testing, but there is definitely awareness that we need to move more away from diagnostic testing into screening. And unfortunately, that's not that simple. So I'm going to go over a few different areas with you today, talk about some market research we've done. Unfortunately, I am going to have to share some of that painful, ugly statistics, one of my least favorite topics. Then talk a little bit more about how you should think about selecting tests. There's lots and lots of media about what's the right test and speak to you about how do you select tests. I'm going to share with you a modeling website that we're about to launch next week, and then run through a couple of case scenarios to try to make it a little bit more real. So one of the jobs of RADDX was indeed to select tests and manufacture tests, and then try to figure out what were the right tests that we manufacture for the communities. We've worked through lots of regulatory hurdles, working closely with the FDA, as well as trying to help sort out for some of our companies some of the complexities around the data, reporting, infrastructure. Now we've moved into the fact that building the tests is one thing, but implementing tests across the country in environments that do not have a history of implementing diagnostics. So implementing tests in communities, in factories, in assisted living facilities, in schools. How do you implement tests in environments that have never implemented tests? What are the communities, schools, concerns? And then how do you actually, then we can finally reach millions of tests to be deployed. The goal.
Sorry, can you share your screen? I don't know if people can see that yet.
Oh, thank you.
No problem.
So we had talked about this earlier. How in the world do you do that correctly? And I'm not sure why it's not sharing my screen. Let's try that again.
Perfect.
Now you can see it. Okay, didn't go very far though. Thanks.
You were doing a wonderful job without slides, by the way.
Well, thank you. Okay, so here we are. So we did a fair amount of community research with market research, and what we found from communities is that they're not just looking at tests, they really are looking at the end-to-end process. How do we start from buying the test all the way to getting the test results back? So it's complicated, and communities are much more interested in knowing how to do this whole process than should I order a PCR test. The company that we worked with was Health Advances, and they were very, very helpful in this endeavor. We looked at a couple of core communities. One is manufacturing. In manufacturing, we looked at both high and low margin, meaning organizations that have the money to buy testing and others that it would be tight, big and small. We looked at schools, urban, suburban, rural, and we looked at assisted living facilities. And that's important because when you think about those types of facilities, you not only have to worry about the residents, but you have to worry about the staff who go home at night, potentially catching COVID, and the fact that the residents so much want to have visitors. So there's almost 3 separate communities within assisted living organizations. So from a community perspective, when thinking about screening testing, they're obviously worried about turnaround time, which I think is great because that has become much more of a concern. People are realizing doing a test and finding out 3 days later that it became positive is almost useless. You can't pull the people out of their community and stop them from spreading if the turnaround time is very long. Cost is obviously not a surprise factor. The logistical and operational challenges definitely are. And then something that we hadn't actually thought about very much was, how do you enforce testing? If you have a manufacturing plant, if you have a school and somebody says, nope, thanks, I don't want to be tested, what can you do? Do you force them to not come in? Do you accept the fact that a small percentage of your workforce aren't going to be tested? But it's certainly something to consider. Additional barriers are very much along the way of why should I be testing and how should I be testing, as well as we'll get into shortly with those painful statistics. How do I interpret the results? And there's lots of rumors about bad tests out there. What are the guidelines in different settings? And I think we know that the CDC has been very, very vague about screening testing. If I do test, what's my liability in organizations? And what are the responsibilities that I have for reporting? So this just reinforces the fact that it's not so much manufacturing tests, which are really important, but also all of the different infrastructure and complexities about implementing a screening process. So when we boiled it down, we came up with a number of questions that we're hearing. Should I test? Should I not test? What test should I choose? If I do decide to test, how often should I test? So we've been hearing things, for example, well, I don't have much money, so I'm going to test once a month. And I'll show you in a little bit that you're almost throwing away your money if your testing protocol isn't based on some science or modeling. Where do I get the tests? You know, as a physician, I had a distribution partner I went to buy different tests, but a manufacturer doesn't have a distribution partner. Obviously, can I afford the test? How do I set up the test? And is there anybody that can help me with this? So that's where a number of solutions are being built within Radix, because we realize that just producing tests, helping manufacturers produce the tests is not going to be sufficient to really help deploy the tests nationally, particularly if we want to move more into the screening arena and away from reactive diagnostic testing. Okay, so here comes the painful statistics, and I suspect many in the audience are far better at statistics than I am. First of all, no test is perfect, and this is a challenge for us to really share in the United States because there is a misperception that there's bad tests out there. Essentially, there are tests with lower accuracy, lower sensitivity, and lower specificity. And when talking with people, I often remind them, if you've ever gone to a physician's office to get a rapid strep, those tests are not perfect. As physicians, we know they're not perfect, and we always put in context where they're coming from, what are their symptoms, what are their risks, to interpret the results of the tests. Next, I think you've all heard that molecular tests, the PCR tests, are more sensitive and more specific. Unfortunately, they're also much more expensive and most commonly found in central labs. And we all know that if you have to take a sample, send it to a central lab, it can take 2 to 7 days to get the results, which makes them much less effective. Antigen tests, including LFAs, and when we say LFA, that's called lateral flow assay, and you think of the home pregnancy test. So those tend to be less accurate, but they're a lot less expensive, and they're much more likely to be available point of care, which means you can get the result right away. Okay, now for the ugly statistics. When testing in an asymptomatic screening environment, the prevalence is very important. And I'm talking about prevalence of 2 to 3%. That dramatically affects the false positive rate, the positive predictive value, and the negative predictive value. So in general, if you're screening, asymptomatic screening, you're going to have high false positives. To give you an example, if you had 100 people and a specificity of 95, doesn't sound too bad, but you will should expect, with a prevalence of about 2%, 2 actual positives and 5 false positives. So the false positives truly become an issue. Therefore, in an asymptomatic screening, if accuracy is important, you might want to consider taking all of those positives and then sending them for a reflex confirmatory test. And that's a good time to use the PCR. And I'll go through a case example in a couple of minutes. So let's distill that down into a little more practical approach. In a screening environment, typically you want to be proactive. You want to pick out the people either who are pre-symptomatic or asymptomatic and get them out of the community so that they stop spreading. So your goal is to get them out quickly. In a screening, obviously cost is really, really important. And that's why we often recommend a rapid antigen test in that setting, knowing that your accuracy is a little bit lower. Turnaround time is really critical to be less than 48 hours. We love the point of care options. The other thing to be aware of is that there are very, very few FDA authorized screening tests to date. We've had conversations with the FDA and they are completely aware of the fact that tests are being used in the screening process. They are supportive of that and only highlight that they need to be done under prescriber for off-label use. In addition, when thinking about setting up a screening process, you actually need a lab waiver, a CLIA waiver to perform the testing. It's not that complicated, but you just can't start doing screening tests. We, to date, do not have any over-the-counter screening tests. As I said, you need to consider and expect a fair number of false positives. If it's really important to get those people back into your workforce, consider confirmatory. And if you are using a rapid antigen, typically you will want to screen more frequently so that you have a chance to catch maybe a false negative, but you also have a chance as the viral load is increasing to catch them on a subsequent day or time. Diagnostic, however, which is where we've been mostly focused, that's more reactive. Somebody presents for a diagnostic test. Even in those testing lines, they're still considered diagnostic. Here, accuracy is a very high priority, and we want to avoid false negatives. So in a diagnostic realm, we're really more focused on PCR or very high accuracy tests. The turnaround time can be important depending on the setting. So for example, if you're in a hospital or you're an urgent care setting or a surgery center, you want the results right away to know how to treat the patient. In other situations, if the turnaround time is longer, but that person isolates for 48 hours or so while they're waiting for the test, it's not the end of the world. And then, as I mentioned, the PCR tests are good solutions if it's really important to avoid false positives. With all of this in the background, we decided to go ahead and build a model to allow people to start to pull all the pieces together. We've heard a lot about wearing masks and contact tracing and other unmasked activities and what tests to use and how frequently. So we pulled together some folks from MGH, CIMMIT, as well as MIT in ISOLAT and developed a model that I'm going to briefly share with you. And I'm going to warn you, we're going to get a hate that password from Google because demo is a terrible password. The website is whentotest.org. It's going to be publicly released, hopefully next week. So I wanted to give you a preview of it. It combines mass contact tracing activities with different tests. There's a very robust user guide to help you walk through it. And I'm going to just give you a flavor. You could spend an hour on this tool, but just to orient you, on the left-hand side, you input how many people are in your organization, whether they're always wearing masks. Let me tell you, no organization is as reliable as they think, whether you have a contact tracing program. And this is a contact tracing program in your organization. So if you get a test, you pull the person right away. You don't wait for public health to reach them in 48 hours. And do you have a cafeteria? Do you have kids playing sports together? Input your numbers and you will see if you have a high accurate offsite lab, an on-site PCR, an LFA, these are the costs per week based on your scenarios, as well as below here are the how many people should be tested in a day. We strongly recommend every single day doing some testing because you're going to be following people rather than do it in one day at a time. And I'm just going to show you how this works. So look here, offsite lab, 29,000, 42 tests a day. If people are really not good wearing masks, all of a sudden you should be testing 100 people a day and it's going to cost you 70,000. If you say, well, yeah, they're supposed to be sitting at a table of 6, but now we are thinking about, they're actually playing soccer together without masks, $175,000 offsite lab compared to an LFA. I'll bring this down so you can see it. The LFA, a little bit less accurate, so you have to do it more frequently. And then I'm not going to go through the details here for you, but I want to show you some of the other features of the model. If you are a hotspot, so lots of COVID in your organization or your community, the testing frequency increases. We have many more details of turnaround times, days in between tests, lots of details for you. Yes?
I apologize for the interruption, but I don't see the screen. I can see still the slide. And I noticed some of the attendees, they don't see that either. So do you want to try to reshare the screen?
Ah, there it is.
Perfect.
Yeah,
Thank you.
so sorry. Oh my goodness. Okay, well.
Sorry about that.
No, I'm so glad you let me know. As I said, that share button we're all challenged with. So I'm not going to go through the whole thing. I'll just show you one more time to orient you quickly. All the different components, how much it costs based on different tests, how often you should test based on your different tests. If you look at this 49,000, if you aren't wearing masks reliably, it doubles the cost and doubles how much testing you should do. There's advanced features for you to put in if you want to change your R0 and some of the statistics. If you want to actually change the parameters of a test you're using, so for example, you have a slightly more sensitive antigen, you can change that. And on the bottom, it gives you more detail if you're in a hotspot versus typical conditions. Lots of different ways to analyze this if you are statistically and scientifically inclined. But if you're looking for just the basics in your organizations, the tool will support some core basics. And as I said, when2test.com will be available hopefully next week. Okay, sorry about that. Now, can you see my slides again?
Perfect. Yeah.
Yes, great, thank you.
Thank you. Okay, so last but not least, I know we're running out of time. I just wanted to give you a couple of scenarios. One, manufacturing plant, 150 employees, 50 are in an office. You're supposed to be wearing masks, 6 feet apart in a cafeteria. You can't close down. Really important. you've got lots of production, expensive. 3 cases in one day are reported. People start calling in sick. You haven't done testing, but now you realize you need to test. Some of the parameters, you need a fast test. You need to solve this quickly. You can't send it away for 2 days. And you really want an accurate test, because any employee who is not on the floor is costing you money. Therefore, you select a point of care PCR test. It's a little bit expensive. You test 100% to get started. To set up a lab, you need a CLIA waiver, you need to find a physician prescriber, you need to get biohazard waste removal, PPE, and you need somebody to actually perform the testing. This is an actual case, by the way. With 100% testing, we found 10 cases on the floor, but none in the office staff, because the office staff were wearing their masks when outside of their office and otherwise just sitting alone in their office and eating in the office. And within 3 weeks, there was no more cases. And the most encouraging output of this is all of a sudden, everybody really started to wear their masks and stop sitting that closely to each other in the break room. So it had a double effect. Number one, the testing allowed people to keep the company open. It gave great confidence to the workers that they were safe, as well as their behavior improved dramatically. And now there have been no further cases. A dental office, here's a scenario. So 15 staff, they're in a financial disaster. They're only able to bring in 1 person at a time, 1 patient at a time. The owner said, gee, if I could test my staff and my patients every day, we could see lots more patients and reduce everybody's anxiety. They said, you know, actually cost is more of a concern than accuracy, because if somebody's positive, I'll send them home, let them get a confirmatory test if it's a staff. If it's a patient positive, they can go home and quarantine for 2 weeks. If they want to get a confirmatory test, that's up to them. So they selected a point of care antigen test. They already had a CLIA waiver in PPE and biohazard waste, so it wasn't that challenging for them. So with that, I am going to quickly wrap up. No perfect test, lots of considerations when you're thinking about screening. Logistics are really complicated and critical, and the RADIX organization is actually working on all of these pieces to help support the deployment of tests. Okay, with that, I'm going to turn it back to Colin.
Thank you, Nancy. That was a wonderful talk. That was really very interesting and lays out all the key issues that we have to understand in building tests that are effective at in these different scenarios. So we have time for, there's been a number of questions that come through. And I think I'll focus on the first question, which I thought is actually quite interesting one, that it speaks to the accuracy of the tests and sensitivity versus specificity. And related to, I'm parsing it a little bit here because it's kind of long, but basically is that what is the risk of using rapid testing when acting as though everything is normal versus continuing with, some other words, not practicing social distancing and things like that, versus incorporating the testing plus social distancing, so layering that on top. Because it seems like false negatives and rapid testing in for example, in a long-term care facility could easily result in outbreak and deaths of residents. But it also result in a lot of people being denied access due to false positives. So your website actually speaks to that, but I wonder if you could have a few words and answer that question.
Great, well, thanks. And yes, that's exactly why we came up with the website. I think there's so many myths out there. First of all, unfortunately, I think people think that testing is the complete answer. If we tested everybody, then it would stop COVID. And you can't, with testing, reduce COVID to be less than what's in your community. But what you want to do is stop and reduce the spread. So as we highlighted in the website, we don't want testing to give people a false sense of security. We don't want masks and social distancing to give people a false sense of security. And combining the two is really the answer. And I was hoping to highlight the fact that knowing the sensitivity and the specificity of the test you're using can give you a sense of whether you're going to be on one extreme, having more false positives, or the other extreme, having more false negatives. So, for example, in an assisted living, you might want to even think about different tests because you really want to keep it out of your patient population. Your workers who are coming in every single day, you need them to work, but you need them not to bring in the disease. For the visitors, if you turn away a visitor one day and say, gee, we're used an LFA, quick, rapid, it came back positive, we don't know for sure if you have it, but you might want to get a confirmatory, that's really not the end of the world if a visitor isn't allowed in. So knowing those parameters is very important, and probably testing the staff frequently, because they're the ones who are going to be the most risky in this environment. Hope I answered that.
Yes, you did. That's wonderful. Thanks, Nancy. I think we're out of time now, but I want to thank you very much for giving a wonderful talk and very illuminating. And for those that still have questions for Dr. Gagliano, that please reach out to her. And as I said, our talks are recorded and they'll be available at the IEEE EMBS website.
I made a clarification. They will not be available immediately. I need to get all the consents form, and also professionally should be edited. I will let the people know.
Okay. But they will be at some point. We'll notify
yes, soon.
all the attendees, both members, EMBS members, and non-members of that. Right. Well, thanks very much, Nancy. Again, that wonderful talk. Our next speaker is Professor David Walt, and Dr. Walt is the Hans-Georg Wyss Professor of Bioinspired Engineering at Harvard Medical School and Professor of Pathology at Harvard Medical School and Brigham and Women's Hospital, is a core faculty member of the Wyss Institute at Harvard University, associate member at the Broad Institute, and is a Howard Hughes Medical Institute professor. He is co-director of the Mass General Brigham Center for COVID Innovation, launched to help coordinate, facilitate, and rapidly develop innovative devices, diagnostics, data analytics, and therapeutics for the most pressing COVID-19 issues affecting patients, frontline healthcare workers, and the community. Dr. Walt is co-founder of multiple life science companies and is a scientific founder of Illumina. He has received numerous national and international awards and honors for his fundamental and applied work in the field of optical microwell arrays and single molecules. Dr. Walt is a member of the National Academy of Engineering, the National Academy of Medicine, a fellow of the American Academy of Arts and Sciences, a fellow of the American Institute for Medical and Biological Engineering, a fellow of the American Association for the Advancement of Science, a fellow of the National Academy of Inventors, is inducted into the U.S. National Inventors Hall of Fame. So we're very fortunate to have Professor Walt with us today. And his talk is entitled Ultrasensitive Protein Assays for Understanding COVID-19.
Thank you, Colin. Very generous introduction. I assume you can see my slides?
Yes, perfect.
Okay, great. And Nancy did a fantastic job of setting things up. So this is great. I can get into some specifics. So I'm going to talk about some of the technologies that we've developed for addressing some of the more, what I would say, research-oriented questions with the progression of this disease using the ultrasensitive technologies that we have available. But first, I'm obligated to disclose my conflicts. I think the one that's going to be most significant here today is the fact that I'm a scientific founder of a company called Quanterix. We use their instruments, we buy their materials at commercial rates. I am on the board of directors, but I am a customer as well. And I am a co-founder of another company that's in the COVID space, Sherlock Biosciences, that uses the CRISPR-based diagnostics technology. I'm not going to talk about that. Before I get into my research, you did hear about the Mass General Brigham Center for COVID Innovation. I just want to give you a brief introduction to that at the request of one of the organizers, Paolo Bonato. And this was really spun up at the very beginning of the crisis here in Boston as we began to experience a shortfall of all sorts of supplies, including PPE. We know about the N95 mask shortfall, as well as the shortfall in diagnostics. And we spun up the center with the intention of really addressing 4 different integrated areas, devices, including things like PPE, but also including some of the devices that deliver care to patients, diagnostics, which I run this pillar in addition to Gary Tierney, who's my co-director at the center, who runs the devices pillar. And then we have data analytics, probably very interesting to those of you in IEEE. And then, of course, there's the therapeutics component that is responsible for many of the clinical trials, including some of the vaccine trials, but also many of the trials that are undergoing for repurposed drugs that we've heard about, and some of which have actually converted into clinical care. We've set up in the diagnostics space a diagnostics accelerator. This is a laboratory that is aimed at acquiring various assay kits, test platforms. We have validation protocols that we apply to all the various tests, whether they're molecular, serological, antigen, or otherwise. And we have full-time technicians that are working, following those validation protocols, and then we independently evaluate those with samples that we obtain from the Mass General Brigham Partners Biobank that are both pre-pandemic, post-pandemic, as well as healthy controls, and do this in a statistically relevant way. We heard some of the comments that Nancy made earlier about how many of the companies that were testing these initially for EUA approval were self-testing and really were not looking at statistically significant or relevant samples based on the prevalence in the communities in which those were targeted. So this is a physical facility that's available both for independent validation and is also accessible to companies who wish to have their tests validated. We also, through the center, have an implementation working group that's dealing with these 4 different implementation scenarios, that is trying to help implement diagnostic testing on a global scale. We've got 8 partners globally that we work with. We also heard from Nancy about sort of dentist offices. That's part of our healthcare implementation working group to pilot some of these kinds of diagnostic tests in various scenarios where we can really get a feel for how well these things work in the real world setting, and then iterate on that until we get it right so that we can come up with some best practices. We do some community epidemiological studies with some of the serological studies, and then we also bring some of these diagnostic tests to underrepresented communities and disadvantaged communities that need more testing because they're in general the most threatened by the pandemic. So I'm going to change gears now and really focus on some things that my lab's been doing here. We invented a technology that allowed, this is about 10 years ago, allows us to access proteins that are at much lower concentrations than what's typically used in the clinical laboratory. The most conventional type of assay for clinical labs is we're all familiar with these ELISA tests, these sandwich immunoassay tests. And of the 325 proteins that we know exist in the blood, about half of those turn out to have some kind of clinical utility, but they appear in this concentration range, sort of millimolar to picomolar concentration range. And the picomolar is really at the hairy edge of the limit of detection. And so the question is, if we could begin to access those proteins that appear in concentrations that are much lower in the blood, what else could we be able to detect? And my lab has really been very actively using this technology to look at infectious disease markers, such as for tuberculosis. We have a big program in early breast cancer diagnostics, looking at proteins that can predict early stages of breast cancer. We operate and have multiple projects on neurodegenerative disease, such as Alzheimer's and Parkinson's, to be able to pick up people as early as possible so that we can support some of the therapeutic studies that are going on with those kinds of individuals. But the important feature here is that by being able to detect lower concentrations than the conventional tests are able to detect, we hypothesize that we should be able to detect earlier, look at therapeutic efficacy earlier, and really do much higher resolution diagnostic tests than what's been previously available. And I understand this is IEEE, so I'm not going to get into very much chemistry, but I think this is something that you can all appreciate, is the difference between an analog signal and a digital signal. This is the conventional way that most immunoassays are carried out, simply intensity of color. As the color develops, you get a more, you measure higher concentrations. These require calibration curves because you need to compare the color to something. Whereas with something like a single molecule assay, which is what I'm going to talk about the rest of the time here, we've converted those signals into a digital readout. That is, every binding event of a protein with an antibody pair gives you a very specific signal, essentially lighting up like a supernova. And so you can see at this concentration, in this image, there are literally 4 molecules that have bound and are lighting up. And here there's something like 12, and here's the blank. And so we think that digital measurements are similar to what all of you do in the electro-optic world. It is really the future of making these kinds of analytical measurements. And I'm not going to get into the details of the assay. It's a single molecule array. What we do is we essentially capture proteins on beads that contain antibodies that are specific to the protein. We then label those protein molecules, those single molecules of protein, with another antibody that recognizes a different site on the protein called an epitope. And then we label that sandwich with an enzyme. So the bead now that has a protein bound to it has an enzyme, and that enzyme has the ability to catalyze a reaction that generates many molecules of a fluorescent product per second. And what we do is we take those beads, we put them into microwells to isolate them, and then that fluorescent product that is produced locally and cannot diffuse into adjacent wells. And so what you see here are where the beads are lighting up. You have a digital 1, meaning there's a protein molecule there, and where they remain black, it means that there is no binding to that bead, and therefore it's a 0, and you just essentially ratio the number of bound beads to the total number of beads. As I mentioned, this technology has been translated from my laboratory to a company called Quanterix. It's based here in Massachusetts, actually in Billerica. They're a publicly traded company. This is sort of the workhorse instrument. It's a fully automated robotic instrument that can handle 400 samples at a time at about a 6-hour turnaround time. And then this is a more sort of research lab system that requires lots of manual manipulations of the assay, but is really just the readout unit. It has an imaging unit. The real key to the workings of this is this disposable unit. This is you'll recognize this in the format of a CD or a Blu-ray DVD. This is made by on the same line that DVDs used to be made. The companies that make these now have converted into sort of a life science tools businesses, just because everybody's streaming music and video these days instead of storing them on plastic. But these are fantastic for biomedical applications, because what we have here is a microwell array that contains 216,000 of these wells that are able to contain the beads that hold the digital signal, and there's 24 channels on each of these discs, so you can run 24 assays per disc, and that corresponds to 4 discs per 96 well sample plate. And as I mentioned, the instrument itself does all the work. So we've used this instrument. Again, I'm not pushing that here. It's just we use this as a research tool for developing ultrasensitive assays. And when COVID began to come into Boston, the lab pivoted quite rapidly. Within 2 weeks, half the laboratory was working on COVID-related activities. And so the first assay that we developed, we call it a high-resolution, high-definition immunoassay, and this is for seroconversion. And what we did is we took the four different viral proteins. You've all seen the spike protein that gives the coronavirus its corona. So this is the full spike. This is the receptor binding domain. That's the part of the spike protein, sub-region of the spike protein that is responsible for binding to human cells, to the ACE2 receptor on the host cells. S1 is another protein that is on one of the spike subunits. And then finally, the nucleocapsid is an internal protein to the virus. And so we display each of these proteins in multiple copies on different colored beads, as you can see here. We then incubate with serum, that is a sample of blood. What you'll be surprised at is, because of the ultrasensitivity of this particular assay, that is our ability to really detect very low concentrations using this digital assay, we use 1 microliter of blood. So that's 1/1000th of a milliliter, and we dilute that into 4,000 fold buffer, which completely removes any possibility of non-specific binding. So this is a really sensitive assay that's able to run at very dilute concentrations with very low sample input. So, a dried blood spot, just a very tiny amount from a finger stick would be sufficient. What happens then is the host's antibodies that they've developed, and there's 3 families of these, IgG, IgM, and IgA. This is the sort of the more standard one, immunoglobulin G. The IgM is the early immunoglobulins that typically form, and the IgAs are the ones that typically will be produced mucosally or be expressed mucosally. And since this is a disease of the lung lining, that is a mucosal surface, and so that's why folks are interested in IgA. And then we just measure all 12 of these interactions using the same kind of technology by labeling it with a secondary antibody, and then with this enzyme, and then putting them into a multiplexed readout capability. It has high sensitivity, high resolution because we're looking at 12 interactions simultaneously. It has a very wide dynamic range because of our ability to do this digitally. And again, we have the ability to multiplex. And you can see, this is from some of our earliest results here. Pre-pandemic, these are the samples that were obtained prior to October of 2019, so before the coronavirus appeared, at least in human populations. These are PCR negative. We heard Nancy talking about sort of false positives and false negatives. There's clearly some false negatives here in this particular sample set. But as we began to look at patients coming into the hospitals, what we found is that with this assay, we could even see seroconversion the day that they appeared in the emergency room as a consequence of our ability to detect extremely low concentrations of these antibodies. And you can see as time progresses, one gets an increase in the production of these antibodies. This is one specific one. This is the IgA to the S1 protein, and the only individual who did not seem to produce them was an individual that was COVID-19 positive, but had immunosuppressive drugs due to a comorbidity, and as a consequence, she did not develop any antibodies because her immune system was suppressed. So, I'm not going to, try to overwhelm you here, but this just shows you sort of, all 12 of these interactions over time, and we can go into this with some deeper data analysis and look at sort of the individual progression of each of these individual immune classes to each of the 4 different specific viral proteins, and get sort of a profile of how each individual patient is responding to the virus, whether they're producing effective antibodies, ineffective antibodies, what the concentrations of those antibodies are, et cetera, et cetera. And this can be used as follows. So here, for example, this is an individual who showed up in the emergency department. We began to monitor their antibodies, their 12 antibody protein interactions over time. You can see that obviously there's differences in the quantitation, there's differences in the appearance of different antibodies over time. So the blue one is IgM. You can see IgM turns on pretty quickly here, but surprisingly, IgG also turned on. And this is sort of not what the textbooks would say, but again, this is the reality. This patient developed a very robust immune response and recovered from the disease. Here's another individual who showed up. We monitored this individual for, you can see, 8 days before they unfortunately succumbed to the disease, never producing an immune response. And so, that's the kinds of things that we're learning by measuring these kinds of interactions. And we've done this extensively. We've run hundreds, now thousands of samples with both a training cohort and a test cohort. With our early stage cases, that is 0 to 3 days, we've come up with, we have areas under the curve of, not bad, 97 to 99% here. And the particular protein interactions that one looks at with the early stage model are these 4. But if you can wait a week, what happens is you now get into a regime where you only need to look at a single immunoglobulin protein interaction, at least in our experience, and that's the interaction between IgA and the S1 protein, and that gives you 100% ability, both sensitivity and specificity. I'm going to just skip the blinded validation just for the sake of time. here, this has been a big question for, you read about it pretty much every day in the literature, in the press, of how persistent are these antibodies from individuals who have recovered. You can see that these are all longitudinal samples. Some have multiple time points here, but in general, what you see is that there's the different classes of antibodies. IgG, for example, there is reasonable persistence of the response over sort of a 3-month time frame. We're now testing much longer convalescent samples, but you can see here, with IgM, that would be expected actually to decrease over time. And I think there is a general trend for some of these interactions that this particular form of the immune response, the early form of antibodies, is beginning to wane, but there does seem to be robust persistence in both IgA and IgG, which bodes well both for those patients who have recovered, but also for those vaccines that we hope will be available next year. We've also developed a ultrasensitive antigen assay, and I'm going to go through this relatively quickly, but this is simply measuring the presence of antigen. In the case that I'm going to show you, we're actually measuring it in the bloodstream, and the reason that we wanted to do that is that we wanted to see if there was any antigen that appeared in the blood of these patients. So we developed these ultrasensitive assays to 3 different proteins, the spike protein, the S1, and the nucleocapsid. What you can see is that, and again, this is in plasma of some of the COVID-19 patients. Not all of them. Some of them were still at the level of lower limit of detection. But clearly, we have both S1 and nucleocapsid appearing in many of the COVID-19 positive patients that are appearing in the hospital. Now, understand that these are pretty sick patients. They're showing up in the emergency department, so they're a little bit of a self-selected group. The spike protein does not appear as often. We don't think it can get transported across the membranes as easily. But what we see here, if we measure both antigens and antibodies, is you can see that as the antibodies in blue are being produced, you see that after that seroconversion, immediately antigens are disappearing. This is precisely what you would expect from a robust host response that binds to the viral proteins, eliminates it from the bloodstream, and this individual now is developing antibodies that are able to clear that virus from the system. We've done this with lots of samples. You can see here that in the early stages of infection, we have in many of the patients lots of antigen. That's what's red. The antibodies are in blue here, and as the disease progresses, the antigen concentrations go down and the antibody concentrations go up. This is lots and lots of individuals over time. What turned out to be really surprising and incredibly useful, and is now beginning to be looked at as a way to begin to change clinical care, is that what we found is that the presence of antigen in the bloodstream turned out to correlate very directly with how quickly those patients needed to be admitted into the ICU, and a little less directly, but still a good correlation with how quickly they needed to be intubated. Not just totally, the total number of patients intubated, but the days between their initial hospitalization and intubation. And so those individuals who had a high concentration of antigen in the blood were intubated almost immediately, and those that did not were able to put this off for up to a week. I'm going to skip Colin because I have just a few more slides, but we're now doing similar kinds of things, measuring all these things in saliva, antibodies, antigens, as well as RNA, and trying to really get some good correlations with things that Nancy was talking about before, which is, how do we use this information to really know who's at risk of transmitting virus as opposed to those who have recovered. And so I'll kind of leave it at that and go to the folks who did the work and the funding agencies, and I'll turn it back to you, Colin.
This is fabulous work. Thanks very much. This is pretty amazing stuff. We have just time for one quick question, and just wonder if you wouldn't mind speaking a bit about how this could be utilized in the context of therapeutics development, because it seems that in many ways this kind of detailed view of immune system response and such kind of is available, but sort of eludes drug developers to a certain extent. So I was wondering if you could just make a few quick comments on that to see how that could be utilized to make, improve next generation improved vaccines or antibody therapeutics.
Yeah, I think it's a great question. I think certainly the serological assays, the antibody assays, I think there's going to be a big area of opportunity there. We heard a lot about those sort of in the May and June timeframe as people were using those to look at prevalence in communities. I think we're going to see those become much more useful as we begin to inoculate individuals with vaccines to see two things. One is, are they producing antibodies? And two, I had to skip over my last slides. Obviously, I was a little bit too ambitious in what I was planning to talk about, but that we can actually predict which of those interactions are neutralizing interactions, that is, those that can actually clear the virus. On the therapeutic side, I think in some cases, what people will be wanting to look at will be some of the cytokines that are being produced in response to the more severe patients who undergo this sort of cytokine storm. And so I think those are going to be much more useful for those kinds of therapeutics.
Great. Well, thank you, David. It's fabulous work. I really appreciate you being here with us today. And but unfortunately, I have to go on to our next speaker. So thanks again for joining us. That was just fabulous work. Thank you very much. Our next speaker is Achilles Kapinides, and from the University of Oxford. So Dr. Kapinides is a professor of biological physics at the University of Oxford and leads the Biological Physics Research Group in the Department of Physics. His group studies mechanisms and machines of gene expression, such as bacteria and viruses, using single molecule biophysical methods in biochemistry. Their studies are mainly based on detecting single molecules of this machinery via powerful microscopes developed in-house, and applying this understanding to develop ultrasensitive tests of biomedical importance. During the university shutdown, his team focused all of their experimental efforts to repurpose a rapid viral detection assay initially developed for influenza to create a diagnostic test for COVID-19 with results attained in minutes, much faster than currently possible. This project is running collaboratively with colleagues from the John Radcliffe Hospital. Dr. Kapinides received his PhD from Rutgers University and completed postdoctoral studies at the University of California, Berkeley. And the title of his talk today is Rapid Viral Detection Using Single Particle Imaging and Deep Learning. So Dr. Kapinides, thank you for joining us today. And it's a pleasure to meet you virtually.
Fantastic. Thank you for the invitation. Thank you for the kind introduction. I would like now to share my screen and see whether it works.
Perfect. Thank you.
Okay. So you can see the main screen, right?
Yes. It's great.
Okay, fantastic. All right, great. So let's get started. Yes, today I would like to tell you how we use single particle imaging, specifically fluorescence imaging, along with algorithms of deep learning in order to do rapid detection of viruses, and specifically coronavirus. So this technology is at an early stage right now, but we're very, very excited about it. We'd like to share it with you and also get feedback and questions. So as in order to start and give you some context for our work, I'll just say a few words about my lab. So our group is known as the Gene Machines group because we'd like to work on machinery that operates on DNA and RNA, and we focus mainly on microbes and specifically bacteria and viruses. Again, our main tool is single molecule imaging. So we operate either in vitro with purified systems that we label with fluorescent probes, and then we look at the motions of molecular machines by monitoring fluorescent signals at the single molecule level, or we perform single molecule imaging inside living cells, like this example. We also use the ability to localize individual molecules with high precision in order to build super resolution images of biological structures and cells. We build our own microscopes for this undertaking, and we have even perfected the act of miniaturizing for single molecule fluorescence microscopes, and we spun out a company to build and support such microscopes. Now, with the understanding of the biomolecules and mechanisms and the instrumentation, we also try to come up with new biosensors and ultra-sensitive assays. So in the past, we've done some work, for example, on rotavirus, and we were wondering whether we can extend this to influenza the past few years. So we initially, we were doing measurements that focused more on looking at nucleic acids, and then we thought that in order to increase the speed of our assays, it would be very useful to turn to particles. So therefore, the approaches that we use focus on intact virus particles, and for this reason, they tend to be extremely quick and require very little sample preparation. Okay, so of course the challenging thing here is to extract features from our image, since the viruses are very small, only about 125 nanometers in diameter in the case of the coronavirus. So if we just review very quickly the viral detection methods, of course we have electron microscopy that can see the viruses directly. There's of course viral culture. There's antigen detection, especially these rapid tests of they use lateral flow, and genome detection. But all these methods take significant time. The antigen detection can be obviously quite rapid, and there's some very promising results with existing technologies. But clearly, it's very important to have complementary technologies, especially the ones that can give results, much more quickly than this time scale. So in the past few years, we wanted to look at the presence of particles through single particle tracking. So, and initially, we wanted to see whether we can simply label particles with aptamers or antibodies that are labeled with fluorescent probes. And in the case of the flu particle, this will give us several targets on the surface, and therefore we can track those proteins. So in this case, if we have multiple fluorophores, we'll see basically a particle that has the approximate diameter of influenza particle, and then performs Brownian motion with as a particle of this characteristic size. If you have just free probes, they will diffuse very rapidly, they will blare out, and therefore if there is no target, you're not going to see any bright particles moving. So in the process of this work, we actually identified a novel interaction of single-stranded DNA that can be labeled with fluorophores that occurs between the DNA and the lipid envelope of the virus. And this interaction is mediated by cations such as calcium ions. But the same principle applies. As the DNA rapidly labels the particles, we can track them, and therefore we can count them. And as you'll see, using imaging, we can differentiate from other viruses. So our experiments involve microscopy with wide field imaging. So as viruses enter the beam of fluorescent light and move, then we can track them and then get information about their size and of course count them. And here you can see an example of single viral tracking. You can see many particles that are diffusing in solution. These are the type of images that we see in the presence of calcium chloride, high concentrations of calcium chloride, and very low concentrations, nanomolar concentrations of DNA. So now if you omit the virus or calcium or DNA or IDDTA to chelate out calcium, you basically get no signals. So therefore the signal is extremely specific for the virus and the combination of calcium and the fluorescent DNA. So therefore its image will give us a particle. We can track these particles, and from the tracks we can get the diffusion coefficients for this population of particles, and that gives us information about the diameter, and therefore we can use it to see whether this matches indeed the diameter of the influenza particles that we use for this experiment, and that was the case. And actually we have the ability to distinguish different viruses according to the size, but clearly this cannot distinguish viruses that have very small difference in size. Now, this method is extremely rapid. So we have a tube with calcium and DNA. We add the virus, mix and transfer to the well, and then start recording movies. So we can have 1,000 frames in just 30 seconds of acquisition, and we get heavily labeled particles immediately. So if we actually see the number of particles as a function of time, you can see that even the first point gives you a very large number of particles. So essentially the labeling is near instantaneous. Okay, and this is very attractive for rapid labeling and then imaging. We also looked at the mechanism of the labeling more carefully. So we saw that the labeling is specific to calcium, although subsequently we saw that strontium also supports labeling through DNA. RNA also gave some significant labeling, but proteins did not. So that pointed out to the need to have the phosphate diester group in the backbone of the DNA, and lengths of DNA from 20 nucleotides onwards gave a very nice signal in terms of binding and labeling. And a key experiment was the one that we did with vesicles of different charts that showed that anionic vesicles are labeled extremely efficiently, and that's what you have also in the viral surface. You have basically the anionic groups dominating. So therefore we put a model that describes how calcium essentially bridges the negatively charged lipid heads at the viral membrane with the negatively charged phosphodiester groups on the DNA strand. And that's how we believe that the virus is labeled very rapidly. So now we can use this approach to look at the different strains of flu, to look at influenza in clinical samples, and either flu A or flu B. And we can look at different viruses as well. Here you can see RSV that is also labeled very rapidly, and we can use the same approach of tracking and finding the size. And here you can see RSV has significantly larger dimensions than flu as expected. And apart from being able to look at the particles in solution, we can immobilize these labeled particles on the surface using simple bidisruptavitine interactions. And then we can look at the colocalization of the signal from the DNA with a signal we get from an antibody. And we can get these two-color images that show this colocalization quite nicely. And these images are similar to the ones that we got subsequently. You will see in a few minutes that allow us to do the discrimination of viruses based on imaging and deep learning. So we completed this work last year in November, where a few people in the world had heard of the word coronavirus, but of course that changed in early 2020. So our world changed very, very substantially, and then we focused our efforts in adapting the technique that we just developed to see whether we can label coronavirus particles efficiently, and then also try to see whether we can differentiate between different viruses of similar size and property. Of course, these different viruses like the more benign human coronaviruses or influenza will circulate about the same time, will present similar symptoms. So it's important to be able to differentiate between different viruses and the particles. That's where Nicholas Ciel is a brilliant graduate student, helped in these efforts. And Nicholas was working with Nicole Robb, a senior researcher in my lab, in order to develop ways to differentiate between different strains of flu using imaging. And then we thought that the method that he developed would be excellent for looking at differences between different viruses. So the idea is the following. So let's say they have two different viruses that have slightly different size or significantly different size and a different propensity of binding different DNAs because of the surface charges they have. So now if we label these particles rapidly and we allow them to stick to the surface and then identify the particles that correspond to these viruses unequivocally, we can take these images of particles and train a network to recognize the particles and their properties that correspond to a certain virus. So when we then come with an unknown sample that comes from this repertoire of samples of viruses that we have used to train the network then will see each particle and then sort it with a high probability as the virus that it actually is. And then by seeing a sample that has many, many particles of the same type, they will be able to call the sample the right way. So in order to be able to do these measurements, we immobilize the particles on a chitosan surface. This happens actually very, very rapidly, again, in the sub-minute time scale. And then we do imaging. So we look at both two channels because we use two DNAs for two different fluorophores. And here you can see the two-color image. We can do something similar in the absence of the virus as well. And then we can look at this zoomed-in region, and then you can see the events that correspond to the actual particles. The rest of them are just the free DNAs that are sticking to the surface. I'll tell you how we generate these images in a second. So the image analysis goes like this. We start with a raw image. We perform two stages of filtering for intensity and then for area to remove very, very small, very large particles. Then we go to the location image and then display both colors, the green and red. So initially we use the red color for this initial filtering. We identify in yellow the colocalized particles, and we keep them in our image. And then we go back and separate the particles that correspond to the viruses to the other particles. And then from this image, we can go to the original image and have these bounding boxes that correspond to the particles that we have captured as unequivocally being viral particles or with extremely high probability. Now, these are the inputs to a network that will be trained in order to recognize them. Here you can see, however, the different properties that we can capture for the different viruses. So this is a chicken coronavirus, and here are 3 different strains of flu, and this is a negative sample without the virus. And when we look at the different properties, such as maximum intensity for the particles, the area occupied by the particles, and the axis ratio, we see that there are subtle but significant differences between the properties of the various particles in the different scenario. And now this can be exploited by a convolutional neural network to be able to do the training and the classification. So these networks, of course, have been used very extensively to identify objects, faces, traffic signs in various images, and they work very, very well for image recognition and classification. So we use a 15-layer CNN network. So we started with these bounding boxes, and then went through a convolution stage with 8 kernels of 2 by 2. followed by max pooling, and we performed this in 3 stages to generate the feature maps that we used then to train the network to recognize specific particles. And then we did this with 70% of the particles that we get from a certain set, and then we save the 30% for validation. So when we do this for individual particles, we get these confusion matrices that allow us to determine the sensitivity and specificity of our method, of our network, for calling each particle. This is not each sample, this is each particle. That's very important to emphasize. So now, this is the target class, this is the input, this is the ground truth. So when we provide then the a positive sample to the network, it will either find it correctly as a true positive or a false negative, and something similar when you provide the particles from the negative sample. And the sensitivity, essentially the true positive divided by the sum, and the specificity, the true negative, is divided by the sum. So again, this refers to a single particle, but we have hundreds of particles per sample, so therefore we can have a good validation accuracy per sample, even if the validation accuracy per particle is not necessarily very close to 100%. So this is some results that show how well our method works when we compare a virus positive sample with a negative. So this is a lab-grown strain, and here we can see the results for the chicken coronavirus, and you can see that it works extremely well. Sensitivity is 95% and specificity about 90% versus the negative. When we go to clinical samples and see the differentiation with the negative, you can see that the sensitivity and specificity do go down, but they're still quite significant. Again, this is for a single particle. And we are able to tell the difference between SARS-CoV-2 and a negative sample with about 70% accuracy for a single particle. So that shows that the method works quite well. It works less well for clinical samples, which is to be expected because they're more heterogeneous. They have different storage conditions, come in different solutions. Often they're of relatively low concentration. There is a residual material. And the other thing that can be complicated, and this is something that needs to be addressed separately, is that you may have other viruses present. Clearly, it's not just coronavirus or nothing. So you may have other viruses that we want to avoid mistaking as coronavirus. So therefore, we looked at the ability of the network to tell the difference between SARS-CoV-2 and the alpha coronaviruses, OC43, HKU1, and LX63 that have been pulled together for the training. And here we can see again differentiation at a level of 70 to 75% between the different coronaviruses, which shows that the network is quite efficient in telling the difference between these different types of viruses. So all these results were taken by using a validation step. So what we did next is to actually do blind testing of clinical samples, giving the network basically particles from a sample that has not seen before. So we did this with positive and negative samples. This is the example for the positive sample. So this was checked with RT-PCR, and we got 173 particles, and 148 were classified as positive, and 25 for negative. So if we look at how the probability changes of a sample being positive or negative, how it changes with the number of bounding boxes, which means particles that are found as positive. In the case of 148 out of 173, the probability of this being a positive is 100%. Of course, it is a positive sample, where the 25 particles here correspond to essentially a probability of 0. So therefore, the outcome here is that the positive probability is much larger than negative probability, and we basically call this sample as a positive sample. So right now we need to expand the number of samples we analyze this way in order to basically get the formal specificity and sensitivity of the method, not on a particle basis, but on an actual clinical sample basis. So to summarize, I described to you a novel method that uses cations for fluorescent labeling of virus particles, and how we can use automated imaging and batch analysis to do the classification with a CNN network. I showed you that we have excellent validation accuracy and very good sensitivity and specificity per particle. And it's important to know that all this imaging and classification can be done in just a couple of minutes, which of course makes this very attractive as a near real-time way of detecting coronavirus. I mean, obviously we have significant work to do, or as I said, to determine the formal sensitivity and specificity, to improve the particle discrimination. The higher it is, the easier we'll be able to do it with fewer particles, and to also translate now our findings to a device or simpler microscope that can be used for mass testing. Here you can see the microscope that we're using for these measurements. It's relatively small, but obviously it's a research microscope. So therefore, the simpler the microscope, the more widely applicable the method is going to be. So I'm at the end, so it's the right time to provide my big thanks and acknowledgements to Nicole, Rob, and Nicholas Cialis, who drove this project and worked really hard during a very difficult time for all of us, and all our collaborators. People helped in my lab at Oxford Physics, our collaborators at John Radcliffe Hospital at Oxford, the imaging facility, and our external collaborators at Pirbright Institute at the University of Montpellier, other sites at Oxford, and an initial collaboration at the Hellenic Pasteur Institute. And of course, a big thanks to our funders. So with that, I'll close my talk, and I'll be happy to answer your questions.
Thank you, Achilles. That's wonderful. Very, very interesting. So just a couple questions. We have a few moments for that. One question is, what is special about your microscope relative to a standard inverted fluorescent microscope?
Right. So the microscope that we're using is a single molecule fluorescence capable microscope, but we are not using this capability. I mean, we're not relying on detecting single molecules. But of course, if you can detect single molecules, that means that you have an ultra-sensitive microscope. However, although I mentioned in the beginning the fact that we can detect single molecules and have super resolution imaging, all this, the images that we analyze are diffraction limited images. Okay. Mm-hmm. So therefore, you do need a very good fluorescence microscope, but it doesn't mean that you need a single molecule fluorescence microscope. And so we're exploring how basic you can go in terms of microscopy. We have even discussions with colleagues that develop 3D printed microscopes that cost a very small fraction of our microscope, and see whether these microscopes can be used for the training and the classification.
Mm-hmm. And do you anticipate any special preparation methods to get a purified sample, or do you think it can be handled, that the method could be implemented with a complex matrix, say nasal aspirate directly as opposed to some?
Yes. So the clinical samples are throat swabs, mm-hmm. and the method that I showed you actually works well with them. We would like to. We are looking at using saliva samples. Obviously, it will be less invasive, and a lot of people will thank us for that. Just evaluate like different types of sample. But clearly it does work. It's more challenging. For example, it is not as easy to get the particles binding efficiently to the surface, which basically requires that we scan more fields of view to collect the particles that we need. So there actually would be worth putting more effort, and that's what we do on the biochemistry side, in order to have a sample preparation that will work very efficiently, because that will reduce the time necessary, and will increase also our sensitivity, because we don't amplify, so therefore we need to be efficient in terms of collection particles.
There are several questions in the Q&A.
Yes, the one question that just finally that what processes are used to select your DNA aptamer in order to optimize specificity?
Right. So right now, we don't really take advantage of any specific. There is a slight specificity for flu, because initially we were using the DNA that we use as an aptamer for flu, but it just works with all viruses. As long as you have calcium, then any virus will be labeled. So therefore, there is not much specificity. So with coronavirus, we don't have an aptamer for coronavirus. Now, that's an opportunity, because clearly if you build some specificity in one color, that may allow you to gain more contrast. So therefore, you'll have something that is bright, and you have some ratiometric expressions that will help you to call the sample. So therefore, that's something that we are looking at.
Wonderful.
But you can apply to any virus with basically the same sequences, which is actually quite attractive.
Absolutely, yeah. Well, thanks very much. This is a wonderful method, and I'm really glad that we had a chance to have a deep dive into it with you today. Thank you very much.
Thank you very much, and thank you for your questions.
Thank you.
Thanks for putting together this forum. It's very useful.
Our pleasure. Thank you. Now we move to the next speaker, and Dr. Ali Tinazli, who is the Chief Commercial Officer at Fluxergy, an early-stage company commercializing a portable platform that consolidates multiple diagnostic tests onto one device. In this role, he oversees all commercial operations, strategic planning, business development, sales, and strategic partnerships. Prior to Fluxergy, he led the corporate-wide global strategy for healthcare and life sciences at Hewlett-Packard, was previously the VP for business development and sales at Sony DADC, Biosciences Americas, and after receiving his PhD, he worked in corporate development at Applied Biosystems, now Thermo Fisher. He currently serves as an angel investor and board member at various startups ranging from cybersecurity to oncology. Dr. Tinazli received his PhD in biochemistry from the J.D. Goethe University in Germany. We're very pleased to have him here today to speak to us with the title of his talk, How the COVID-19 Exposes the Flaws of Current Health Testing.
Hey, good morning, good afternoon, good evening, everyone. Thank you very much for inviting me to speak about the challenges in health testing and how COVID-19 exposed the issues. And let me share my screen just a second. Can you see my screen?
Yes, thank you.
Okay, great. Very good. So I have a technology bias, as I spent most of my career in academically in biophysics and corporate-wise in Sony and HP. So I have some tech bias here. So what's interesting about COVID-19 is it shows problems which we all have been aware of before, but it became more imminent this year. And there are also very exciting technology solutions around hypermobility. What does it mean? Microfluidics for Health 4.0, and to have basically tools for new medicine. Now, what's interesting is we all in the field had been waiting for the so-called disease X, and that's a Forbes article from 2018. So we all had been, and I'm personally involved in point of care technologies for numerous years, and I was always kind of mentally ready for these type of events. Obviously, whenever it happens, people are always surprised that it happened. So it started last year, December, with COVID-19. However, there are also other health emergencies we are not really aware of in the mass media. So that's the article from the WHO a couple of days ago. So still we have many issues to tackle with. And when we summarize the issues and the challenges we have in healthcare, we have the issue on infection S, and after COVID-19, something else may come, perhaps even something worse. What personally concerns me are drug-resistant superbugs. We need all the better solutions to address those. On the other hand, we see another mega trend, digitalization, digital transformation, which is definitely accelerated by the pandemic. So there are some technology solutions to have more remote access to healthcare and healthcare services, which ultimately is driven by technology convergence, which will lead to an effective decentralization of healthcare. And what's also interesting is, I think as soon as we have more testing available, you will also think of other applications in the field of wellness, as we have aging demographics in many, many countries. People are getting older and you want to stay fit for a longer time. You also can think of healthy aging programs. Now, all these megatrends have in common that it's a major change in healthcare with technology implications, and that's the IEEE forum, so I like to start my talk with technology, that there are technology implications which are already out there, but now in the context of technology convergence, being put together to really transform healthcare. And these are the different tech implications, and perhaps to mention just a few of the most important, I think, miniaturization, making things smaller, digitization, which are enabling this decentralization. And I think what we have now with the IoT and 5G networks coming up, cybersecurity will be extremely important. At the same time, the decentralization will be big time pushed by 5G networks. And that's really what I love about this whole industry now, because we can speak about microelectronics, we can speak about microfluidics, we can speak about big data. So that's really now the technology convergence, which can help us to not only find solutions to deal better with COVID-19, as we had seen in South Korea. They had been very successful in contact tracing, for example. And that's what I also heard many other interesting details from my friends at CGene. And they did a great job, I think, in really minimizing and really literally containing the disease in the early days. And I think these are the technology tools which we can use. Now, speaking about digital health, so digital health is a topic for many years, right? I mean, at least back in 2010, I think it started, people talking about digital health. So basically, the key notion of digital health is you don't have enough physicians, you don't have enough practitioners, providers to really provide strong support of the entire population, not only in the US, but worldwide. That's a worldwide issue. So digital health obviously is going up. It's a great opportunity. And basically the promise here is to use digital health, but also decentralized testing solutions as preventative measures to make basically healthcare not only more effective, ultimately it's also about the dollar. So you need to make health testing basically, or healthcare much more affordable. And that's, I think, one important notion, the cost control. And when you prevent, you can basically control the cost and save money. And here the technology drivers on what I call healthcare forest, basically the combination of computing, AI, machine learning, big data, and sensors is basically faster, cheaper testing in general, and then also accelerating the, let's say, clinical trials, increasing connectivity as supported by 5G networks, and then how to manage big data. Now, if we have basically these tools, then these tools can help to lower the cost, which we have right now in healthcare. So there are different cost increase factors. We all know about that the healthcare system as it's right now, especially in the US, but not only in the US, it's a worldwide phenomenon. Healthcare is getting increasingly unsustainable. And there are now technology solutions based on telemedicine, mobile health, EMRs, to basically make healthcare better accessible, remotely accessible, by that saving time and money. And what we also observe when I look at my discussions with different providers and payers, COVID-19 definitely accelerates the digital transformation. Now, speaking about digital transformation, when you speak about digital, you also have to think of the digital infrastructure. That means you have, on one hand, the data generation on site, locally, but then you want to share these data and make these data available. And when you look at the evolution of IoT and big data, back in 2010, you had worldwide only about 300 million devices connected through an IoT. In 2016, we had already 30 billion. And these days, I would expect that we have about 100 billion devices connected through IoT networks to manage big data. Obviously, cybersecurity here is getting increasingly important. Now, when you connect all these different assets, then you have basically Health 4.0, basically combining hypermobility and microfluidics. Hypermobility is important for the decentralized testing and the digital transformation. Microfluidics is important for decentralized, microfluidics-enabled health testing. And when you see at the evolution of health testing, back in the ancient days, it was highly personal, but access was very exclusive. You had to be an emperor. And then as the science, as medicine became more often science, especially in the past 50 years, I think we had great advances on a lab test or in central labs, which had been very important to standardize and to maintain quality of health testing. That's why we have all these great reference lab companies which do a great job. But now what the pandemic showed us is that having the test sitting in the central lab is a great asset, but if you need it urgently and if you need it on a community level, then you need to have decentralized tests. That's extremely important, and decentralization is enabled by nanomicrotech. And if you do more decentralized testing, it will also help in personalize the treatments. And that's all basically also enabled from the, let's say, from the data side, looking at building healthcare IoTs and basically grant democratized access. Now, when we summarize these key trends shaping healthcare, we have on one hand the convergence of technologies. We have consumers which are kind of capable of keeping track of their body metrics by smartphones, for example. We have changes on the regulatory side. I think also the EUAs and also in general, I think the acceptance of digital models, also having telemedicine services more and more reimbursed. These are great changes. And ultimately, to apply the digital revolution, which we experience on the consumer side, to apply these to healthcare. And so this shift basically will help us over the next 10 or 15 years to have really a decentralized, connected, preventive, and personalized model for treatment and testing. Now I've summarized different assets. At the end, I will land on how to use this for COVID-19. But this is basically about really setting the stage for new type of health testing. One issue in today's healthcare is we have imprecision medicine. Like one drug which is prescribed for a certain condition has different impact on different people. In some cases, it works very well. In some cases, it doesn't work very well. That means we really need to stratify, personalize the different patient cohorts. And basically, we do not have the tools already implemented to make precision medicine happen, but we have already the foundation set. And healthcare is quite complex, right? Because 20 years ago, when the human genome got fully sequenced, people had been very excited about having the human genome as a blueprint to really understand everything about healthcare. But once after 20 years of the human genome, of the completion of the Human Genome Project, we still don't really understand everything. We're actually far away even to explain this beautiful metamorphosis from a caterpillar to a butterfly. Ultimately, we need to slice it down into a multi-omics level. That means we have really to understand health or well-being on different levels of our omics. And this can be addressed by testing. What I think is diagnostic testing is totally undervalued at present. What's interesting is when you look at the total healthcare TAM, which is worldwide about an $11 trillion market. In the US, healthcare is a $3 trillion market. Only less than 2% of this total TAM, of this total market, are being captured by diagnostics. But these 2% have impact on more than 60% of critical decision making in healthcare. That means if you do a mistake on the diagnostic side, it can put you on the wrong track for treatment. It can put you on the wrong track for surgery or other type of expensive treatments. That means the value, the dollar value associated with health data, with health testing, actually is much higher. And you will see this actually in liquid biopsy in a quite interesting fashion, where you can basically through more frequent testing, can really understand when a cancer will start or not. Now, what we see as a great opportunity in health testing basically is to move from today's standardized reactive in-person care to personalized preventative and remote care. And you can basically address this on different levels. So you can start obviously in physician offices, right, or in other provider settings, but then also move over time into home settings. And that's really exciting possibility as a moonshot vision over the next 10, 15 years. I think it will happen. As of today, healthcare is kind of at the edge and can move with cyber-secure tools into homes. Now, I joined last year Fluxology, So I've left IHB because I found at Fluxology a very exciting moonshot vision and value proposition, which made me move to Fluxology. I saw here an exciting opportunity to address the issues in point of care. So one of the major issues in point of care actually is you cannot address, with most devices, you cannot address complete panels. That means you may need for a certain disease condition a cell count, and for another disease condition you may need an immunoassay. In some cases you may need the combination of both. You may have a combined need for cell count and immunoassay at the same time, for example in chronic care management. And here I see some exciting outlook on the Fluxology platform. So we have basically a platform here which provides, depending on the type of assay, fast results within 15 to 45 minutes. What's important is, and I will speak more to this in detail, is the test card consumable, which is low cost. We set up high volume manufacturing, and the all point of care systems, I think right now, all new generation point of care systems are speaking about sample to answer workflows. Now, what's unique about our system is the combined multiplex multimodal capability, which I will show shortly in a few examples. And also being highly accurate is important, and that's obviously a target which depends on the specific assay. But we are also aiming fundamentally to turn these workflows into clear-wave processes. And obviously, all our motivation is to reduce the healthcare cost by early detection, fewer physician visits through remote settings. And now, when we look deeper into our platform is based on consumables which we produce in-house. These are test cards, Fluxology test cards, and based on the microfluidics functionality which we can control, we can either assign it for PCR testing or for immunoassays, for clinical chemistry panels, cell counting, or we can also mix some of these modalities. Obviously, depends always to have the right clinical problem statement. So you, not only because you can do it, you should do it. So you need always the clinical problem statement that it's a meaningful combination. But that's a great tool. All right.
It's back again.
Okay, can you hear me?
Yes, I do.
Okay, great. Okay, great.
Now.
Okay, great. And so basically, on one end, we have our test card consumables, which are one important foundation for the multimodality, basically the ability to address different types of tests on the same platform. On the other hand, our analyzer, and we are very transparent here. When you look at the cross-section of our analyzer, you see basically it's a combination of the real-time PCR detection unit in combination with the colorimetric detection for endpoint immunoassays. We have also electrical potentiometry to detect small molecules, and we have also an imaging cytometry module built in. And this combination with the test card will allow us basically to address complete panels. Now, I spoke about digitalization. That's also a very important aspect here. In our case, our analyzer has a software which has advanced algorithms, which we can also build further into AI machine learning agents for complex data readouts, data interpretation. Our analyzers work as an edge computer. It means you can operate them offline and basically do the data analysis on site. But you can also combine and connect it in a cyber-secure fashion, in a HIPAA-compliant fashion, to cloud solutions from third parties, basically connected to hospital systems or retail apps from retail clinics. And these are the different types of partnerships we're actually discussing right now with different partners. And what one important aspect in point of care is always the throughput. Because in point of care, people basically ask you for a Ferrari school bus. On one end, you want to have fast turnaround time. At the same time, you want to have high sample throughput. But to have both is technically not very straightforward, because it would jeopardize the value proposition of either high throughput or fast turnaround time. One workaround we have defined this to basically cluster our analyzers, and our analyzers have the size of a smaller coffee machine. You can basically daisy chain up to 256 analyzers to run, or you can scale it down again, all controlled by one workstation. That means in pandemic times where you need higher throughput at the point of care, you can connect more devices and scale it, or in post-pandemic times, hopefully soon, you can basically scale down to lower throughput. And that's basically also one of the important bottlenecks we had seen in the past in point of care, and why point of care did not reach a very deep market penetration before the pandemic. Now, when you connect all the different elements of our system, you have on one hand the test card consumable, which accepts different types of samples. In case of COVID-19, it's a nasal pharyngeal swab initially, connected with our Fluxology analyzer to perform the testing, upload the data and manage these with our proprietary software, which is advanced algorithms. Then you have basically a complete sample to answer test, which helps you to generate and manage health data via edge or cloud computing. Now for COVID-19, we have developed earlier this year a real-time PCR test, which provides results within 1 hour. And we have basically a very short hands-on time. It's below 2 minutes. We are also in discussion with the FDA to turn this into a CLIA-waived product. So we spoke with the CLIA group of the FDA to basically simplify the workflow even further. And right now the EUA is pending for this, and we expect that the EUA will come soon. What we also work on parallel is, this speaks to the multimodal and the multiplex nature of our analyzers. We are developing right now a combined test which performs simultaneously COVID-19 PCR and antibody test on the very same test card. That means you see here in the schematic, you see basically 2 different types of sample loading ports. One for the PCR, which is based on the nasopharyngeal sample loading, and one for the antibody test, which is an LFA, which hosts basically finger prick blood samples. And this multimodal card is right now in development. We expect to have this available early next year. And in parallel, we are right now developing a syndromic 4-plex real-time PCR test card for respiratory diseases. This will be basically a combined COVID-19, RSV, and influenza panel. Now, when we put all these assets together, you still have to manufacture. And we have received this year additional $30 million funding to expand our manufacturing capabilities. So we are designing, developing, and manufacturing in California at our headquarters in Irvine. And we are right now expanding our production capacities to obtain by early next year a monthly output of about 1 million tests per month. And here I'm speaking about the reagents, the test card consumables, and the corresponding number of analyzers. These are things we are lining up right now to be ready basically as soon as we have our EUA to roll this out across the market. And we look at different community types when we speak about the market rollout. On one hand, we have done different validation studies. Some of the organizations I can mention here is UCSD and Mass General. Both have been published in PR and also being covered on Genome Web. And here they're speaking to numerous health systems and labs to basically make COVID-19 testing available within 1 hour at high precision in more traditional healthcare settings. On the other hand, in discussions with different types of retail clinics or urgent care clinics, we are discussing about deployable formats of our analyzer for 1 hour testing of COVID-19. And these are different scalability options we have, and also think of pool sampling. We have formed with Dr. David Smith at UCSD a pool sample study, which would allow us to also pool patients, which makes especially sense at low prevalence populations. And then a very exciting topic is workforce reopening, especially in the field of entertainment and hospitality. Here we are also thinking and working actually on mobile formats, mobile extension of high complexity labs for the purpose of workforce reopening. And on this, we actually will have also a press release next week coming. And so we have basically laid out on one hand, from our company's perspective, our strategy, how to be part of the solution to fight the COVID-19 pandemic. And on the other hand, we also put together different types of technology assets, including manufacturing of scale, economy of scale, to basically provide not only solutions for COVID-19, but also to set a long-term for decentralized health testing. Now, The big question is, when the different labs and providers worldwide have all these great devices from different diagnostic companies, we have now installed worldwide a pretty strong, compared to the pre-pandemic times, a pretty strong network infrastructure for decentralized testing. Now the question is, what to do with all this testing infrastructure after COVID-19, right? And that's a very important point, I think, to address, because when payers when payers and providers agree to basically to set up new healthcare testing infrastructures, you also want to see what's the long-term advantage of having these type of infrastructures in place. Now, what our vision is, especially with our multimodality, basically with our ability to detect on one hand nucleic acids, proteins, cells, and small molecules, we see an exciting opportunity to really transform health testing from today's, let's say, more sporadic testing to complete diagnostic care. That you basically have a continuum of testing solutions which range from your healthy state down to chronic disease states. And just to give you one example, when you, for example, look at wellness testing, well-being, how well is someone doing? When it's like when you look at the WHO, let's say, definition of healthy, healthy is not really well defined. That means you don't really know what healthy is versus unhealthy. And there are also very often underlying chronic conditions which people don't recognize, such as chronic inflammation. So we do some work on chronic inflammation, for example, to provide longitudinal testing opportunities for chronic inflammation, because chronic inflammation, for example, can give you downstream even more severe conditions, such as cardiac conditions or cancer. And here, basically, our vision here is to, based on the different disease segments, disease areas, to define together with our collaborators biomarker sets for each type of disease state, which will allow us basically to personalize the understanding of someone's well-being. And here you also have the interesting aspect when you look at food, right? The food intake, food consumption are one of the most important environmental exposures, and these type of exposures impact your well-being. That means you will see changes on the multi-omics level. And when you look at the Fluxity platform, the multimodal platform from a scientific perspective, it's actually a multi-omics testing device which can bring precision medicine to the point of care. And that's exactly our ambition to have, basically, with the multimodality, to look at different omic information from humans, and then to process these, and then basically to turn this into reality at the point. And this obviously is a moonshot vision. And in this context, we also speak with numerous partners on the healthcare, but also on the consumer side. Now, the outlook in a post-COVID-19 world is we still may have another infection X, but we will be much better prepared than before. I think we got great lessons also collectively from the pandemic. We still will have to consider and fight drug-resistant superbugs. So I think increased testing will be very important. We will have installed established digital health routines, such as telemedicine, or fully reimbursed by payers, which is a very important aspect. We have further technology convergence, even moving testing to people's everyday life in a more immersive fashion, which basically will help really to not only decentralize health testing, but also the entire healthcare, and basically to also improve the quality of life of aging population. Thank you very much for your attention.
Well, that's excellent, Eli. Thanks very much. It's quite a vision and very enjoyable talk. We have time for a few questions. One question is, what is the sample prep chemistry? And so do you need to have sample prep ahead of putting the sample into the card, the chip, or is that also included with the chip inside the chip itself to be able to take a raw sample and then process it?
And so this depends now on the type of assay. In case of our COVID-19 PCR, we take the nasopharyngeal swab, put it into the UTM, and then we mix it with the master mix basically, and apply then the combined master mix plus sample onto the test card and load it into the analyzer. Mm. And it depends. We have also other tests. We have basically worked on a salmonella test or C. diff test, which obviously works with different types of samples. It depends really on the sample. We have also the ongoing work in the field of inflammation markers with finger prick blood, which again needs a different sample prep. So the sample prep, basically the front end, differs each time. And also when it comes to the multiplexicity, really it all depends really on the type of setting. And that's why it's also important, I think, to understand the vision, but then also the technology constraints. That means, for example, if you want to do multiplex with the finger prick blood, then this gives you typically 200 microliters, which is good for a 3 to 4 plex test. That means it's also extremely important on one hand to understand the technical limitations of any sort of technology from a detection side, but on the other hand also to also have the right on the clinical side to understand the clinical problems which and so
Ali,
that we can
wait a sec. Okay, you're back.
Okay, and so basically it's important to start with clinical paths to understand which kind of test panels make sense from a let's say from a clinical perspective. Not only what you can do technically, but also what makes sense, and also what provides clinical value which can be reimbursed.
Got it. Okay, thank you. Last question is, what is the will the test cards be reusable or one-time use?
These all things, and so basically the factory which we are setting up right now in Irvine, California, will help us to manufacture up to 1 million test cards initially, early next year. And we also did this ramp up in the context of COVID-19, but not only, because ultimately we want to make this accessible and available as a longitudinal testing tool that, for example, in the look at chronic care management, which I think is widely underserved, that you can basically offer testing which are closer to the patient, not necessarily in homes, but closer to the patient. And for this, it needs to be pretty much low cost, that you can do testing not only perhaps once a month in let's say chronic care, but perhaps even daily. These are and basically our team spent in the past 7 years quite a bit of time to really drive the economy of scale and the manufacturability of our consumables. And now it's the time to really ramp up. And this is definitely a very important aspect.
That's wonderful. Thanks very much, Ali. That's a great talk and a great vision.
One question.
Oh, yep. Sorry, yeah, Madden.
Your technology, serological technology, is it different than commercial or other serological testing?
So our platform is a horizontal platform. That means we can basically import any sort of third-party assay, a chemistry, and to look at it really as a horizontal platform. And early this year, we decided with our own team, so we have about 70 plus employees, we decided to develop with our own team our very own real-time PCR test for COVID-19, but we also work on other tests such as C. diff or salmonella, and then we basically use pre-existing assay chemistries. But earlier this year, it was just necessary to make our own steps here.
Thank you so much. I appreciate it. Thank you.
Great. Well, thanks, Ali. We have to move to the next speaker, but thanks again for joining us today.
Thank you very much.
I apologize for a bit of background noise. I think someone's drilling on the floor below me. So our next speaker is Dr. Andrea Zacchetin from the Polytechnic University of Milan. He's an associate professor at the university with research interests in mechatronic systems, robotics, and automatic control. He's a member of the IEEE Robotics and Automation Society and is a co-founder and co-chair of the IEEE RAS Technical Committee on Collaborative Automation for Flexible Manufacturing, and chairs the Italian chapter of the IEEE RAS, or RAS. Dr. Zacchetti is a co-founder and member of the board of directors of Smart Robots, a spin-off company from the university. He received his master's in computer science engineering and his PhD in information technology, both with honors from the Polytechnic University of Milan. And we're very pleased to have him here today to speak on the topic of a collaborative robotic solution to partly automate SARS-CoV-2 serological tests.
Yeah, thank you very much, Colin. So I will start sharing my screen. I think that you can hear me, right?
Yes.
Yeah, great.
Loud and clear.
Fantastic. So I will share the screen. Let me know when you see the slides.
There we go. Perfect. Thank you.
Okay, full screen. So Great. So thank you for your kind invitation. So as you said before, I'm a roboticist. So the thing that I'm doing mostly is playing with robots in my lab. And the field of application I'm usually focusing on is manufacturing. What I'm going to present to you today is indeed this robotic solution for partly automate, and then we will see why partly, SARS-CoV-2 serological tests. Yeah, before starting, I want to give you some background of my research. Well, that is the lab where I'm actually working. This is on the right, you see a PhD student from our lab. On the left, you see our rector. And that was the inauguration day of our lab. That happened actually in the second half of February. And actually a few days before the outbreak of the pandemic here in Italy, which actually happened a couple of days after this event. This is where we used to work in the pre-COVID era, I would say. And this is more or less the inauguration day, something that is some sort of unbelievable today. So it was so crowded, and we were very happy to show the people where we work and what we work on. And what you see there this is me presenting our research. And this is more or less the setting that we have in the lab. We work with collaborative robotics. And for those of you who are not familiar with this technology, I would try to spend a few words just to describe what I hope that I'm pretty sure that you're familiar with robots, but probably not with collaborative robotics. So we'll try to spend a few words on that. Well, typically what we work on is robots that work with humans. So what you see is there are 4 humans and 1 robot actually. So still we have our rector here, which is seeing our collaborative spray painting application. So what we do is that we try to develop algorithms to allow robot working with humans in order to help humans in performing tasks. So this particular application is kind of relevant for the bioengineering community, because what we are trying to do after actually right before the pandemic is to help humans to have some relief from musculoskeletal disorders. So imagine here you have a spray painting tool, then imagine that you have to paint right here, so probably your arm is fully stretched, and you have to support a lot of weight because of the painting here. And so this is what we were working on right before the pandemic. And now you know what happened, right? So after a few days from this event, we were almost completely locked down in our homes, and I mean, things were getting tragic in northern Italy. So what we start doing is to think about collaborative robotics application to help for COVID-19 testing. So collaborative, as we have understood, is robots working with humans without any safety fences, without any kind of barrier that separates the human from the robot and vice versa. So they kind of share the same workspace, and they are more or less interchangeable. But as we will see, there are peculiarities for human work and peculiarities for robot work, as we will see. But just to give you an introduction, an overview on what collaborative robotics is, so there are a lot of keywords that can be mentioned here. The first one is robots are quick, programmable. So you can easily set up a collaborative application in, I would say, few hours of programming the robot. In order to set up a collaborative application, a robotics application, you have to afford quite a small investment, as we will also discuss in a while. And then, as we have seen in the example, there are improved ergonomics for the human operator because the robot is taking care of some strenuous or dirty tasks. And because of all of these components, you basically have a quick payback in your investment. Last but not least, because of the flexibility and the ease of use, well, collaborative robots and collaborative robotic applications have a very quick redeployment effort. So a very short redeployment time. So if you want to reprogram the robot to operate on task B instead of task A, that can be easily done in, I wouldn't say in minutes, but in a few days, which is not possible with traditional automation or traditional industrial robotic application. So that is more or less the environment where I used to work, and I'm still working on these days. But when it happened, the pandemic, so I was reasoning about using this technology or proposing this technology to help for the testing of COVID-19. So let's have a look at briefly how the paradigm of collaborative robotics actually work. So when I assume that we are now in a factory, so I'm starting from a manufacturing paradigm. So we typically have two components. So we have two axes for our reference. One is the throughput, whatever you're gonna produce, and which is more or less correlated with the investment. So the more you invest, the more throughput you expect. And the other one is flexibility. So flexibility means that the setup time for changing from product A to product B, or from task A to task B. And of course, the component that is maximizing flexibility is human labor. So you can tell this girl here to switch from one task to another, and that is going to happen suddenly. And then from the other side, of course, you have a small throughput and possibly a small investment, because you don't have to set up the environment for the human to work in. On the other side, we have hard automation. Of course, you have to pay for purchasing hard automation, so machineries. But of course, in turn, you have a very high throughput. But in turn, you have a very low flexibility. So we are here with a very high throughput, but on the other side, we have to pay in flexibility. And this is exactly here is the region where collaborative robotics come in. So this is where you have collaborative robotics applications. So you have a robot, you still have a human operator, which is basically the intermediate solution from completely manual labor and completely hard automation. And in order to switch from here to there, you just have to add a robot, basically. And this is what is quite common in manufacturing. And this is where we started from. And we ask ourselves whether or not this paradigm can be also applied to another field of application, which is healthcare, and specifically to fight the COVID-19 pandemic. So this is more or less the scenario where we were starting working on at the end of February or beginning of March. This is exactly the same paradigm that we have found in hospitals. So you have small facilities where you still have manual labor, high flexibility, small investment. We do have very hard automation. This is a liquid handling machine with a very high investment, very high throughput, but small flexibility. And here in the middle, we probably have collaborative robotics as well. So we have intermediate throughput, but very high flexibility. And this is exactly the same paradigm that we have seen in manufacturing, but now we are in healthcare. So the question was, can we use the same paradigm also for increasing the capability of testing, so the throughput of COVID-19 testing using collaborative robotics? And the answer was, we started this collaboration with European Institute of Oncology, and we was indeed developing this serological test and then try to automatize the fractions of the tasks that were susceptible of automation. So before actually showing you the application, I will start showing actually how the manual test works actually if completely developed by a human technician. So we will start with this side here, and then we will try to understand how we actually move to collaborative robotics application. So this is more a kind of a dense chart with all the information we got from the department, so the immunology department of the Institute of Oncology. So this is the testing. So this is serological, it's quantitative serological testing. It's based on an ELISA protocol. So for those of you who are not familiar with this, so basically you have a well. You put there the coated the protein of the spike protein of the virus. Then you put the serum, and if the serum has antibodies, they of course they attach to the protein. Well, if you add some chemical reagents there, you basically have some sort of coloring of the plate that realizes whether or not you have antibodies in the serum of the patient. So you basically have an artificially grown spike protein of the SARS-CoV-2 virus, and then you test the serum of the patient in order to understand whether or not the patient has developed antibodies. This is actually working for both IgM and IgG antibodies. So this is the Gantt chart of the protocol. So you see there are several phases. This is actually what happens from here on. So you basically is the part of the protocol that assume you already have the serum. And so there are colored activities, which are they basically divided into two parts. So the dark blue is the dispensing activity, so where you dispense the reagents. And the light blue is where you wash the plate. So basically at every step you have to wash the plate to remove the excess material. And they are basically interleaved. So you first dispense, then you wash, then you dispense again, and then there's some incubation period. And then you basically repeat with other reagents or with the serum of the patient or with other reagents in the end. And you basically interleave those activities. So if we divide dispensing from washing activities, what we see up there is that basically there are 20 minutes plus incubation of processing time. So if we sum up all the timing here, what we get is in total 20 minutes. So you see that the assay is kind of longer because of the incubation period. But those incubation period are not requiring actually any hardware nor any human activity. So they're not so relevant for understanding the saturation of the personnel. So you have 20 minutes, of which 33% is spent in dispensing and 67 is spent in washing. And if we look at the ergonomic stress of the activity, you have 744 time actions for each well plate, so for each assay, which is more or less the 20% for dispensing and the 77% for washing. So those are basically the activities that you do with your thumb and the micropipette to do the test. So what we see there is that we can easily divide into two parts. One is the added value activity, which is dispensing the reagents, and the non-added value activities, which are washing all the plates. And this is where we started from. So we asked ourselves whether it was possible to assign those non-added value activities to the robot while still having the human to dispense all the reagents to go on with the protocol. This is exactly what we did. So we have seen that 77% of the pipetting operation were actually of possible automation, and 67% of this of the time spent was actually during those washing activities. So we were focusing on those because, of course, you might imagine there are several musculoskeletal injuries or the pipetter's thumb and repeating this activity all day long. So if you are interested, there's a nice paper overviewing all the possible diseases in experiencing this prolonged activity for all the time in every day. So this is where we started, and we were focusing on how we could actually remove the human effort in performing the washing activities of the plates. And this is where we started from. So this is we started this analysis on the role of the thumb, or the rule of the thumb, if you prefer. So the role of the thumb is pushing down. So we measured the force that was needed to push down the pipette piston, and it was 13 newtons with a stroke, or a full stroke, of 20 millimeters. And there was kind of a stiffness of 650 newton per meter, which is quite high actually, if you continue performing this task for all the day. And we started to think how we could automate this. And the natural solution was actually a pneumatic cylinder. And so if you inject some air here, and you have a cylinder here, and of course the air is pushing here. And if you leave this open, the air which is inside there is going out. And then this way you're pushing down. And of course, if you change the other way around, you're actually pushing up the piston. And so we started thinking about dimensioning this, this tool here. And with the typical value of automation, which is 0.8 megapascal, and we were starting thinking of the sizing of this tool in order to exert 13 newtons. And then we figured out that a standard automation piston was actually already a good choice. So we selected a 6 millimeter diameter, and we started doing experiments with this. And this is exactly what we did in our lab. So this is the design of the application. So you see here the piston. We have designed the tool for the robot to house the micropipette. We were using an 8 channels micropipette because, if you remember, this is not an automation solution, it's a partial automation solution. So a 96 wells is something that the human can still handle. 386 is something that the human cannot really handle. So we started with a 96 well plate, and this is exactly what we designed for the solution. So there's a dual arm robot that you can see here. It's collaborative, and it is a dual arm. So one arm is handling the micropipette, is moving around the pipette, and is also responsible for activating the piston. And on the right hand of the robot, we have an handling task, which is moving the well plate from one position to another position here. So one robot, or one arm of the robot, is responsible for moving the well plate. The other arm is responsible for the actual pipetting task. And this is what we achieved in our lab in, I think this is more or less June, even though this video has been recorded in September, I think. So this is the actual setup. So I'm starting the video so that you can see. So this is me. I'm putting down the well plate there. Down to this small tray, there's a sensor that tells the robot that a well plate is available to be washed. So the robot recognizes this. It picks the well plate. It drops off the well plate in front of it, and it starts filling. This is just alcohol, and it is starting now the washing procedure. This is repeated for the well. It's actually repeated 3 times in a row, and there 4 times in the serological assay. So this is kind of boring task that we have been able to automate. So I think that I'm kind of let the video going on, but believe in me, it's always the same. Now just removing the liquid, so the washing liquid, the washing solution. And this is actually performed 3 times. So 3 times filling and 3 times removing the washing solution. So after that, so the robot is still going with probably a second round of washing. And in the end, what happens is that the robot is done with the task. As you see here, it is completing the last rows. I picks the well plate and it drops off in another spot where the technician can actually take it to continue the test. So we basically have an automation solution which is very simple to use. So there's one drop-off station here where the technician actually puts the well plate to be washed. Then the robot takes the well plate, washed it, and then there's another drop-off station for the robot to deliver the washed plate to the technician. Now the robot is on hold because there is no more plate to be washed there. So as soon as I put it another one, then it will start washing the other one as well. So this is how it works. So let me just actually introduce how we handle the project. So we started the project, I think, in early April, just after having figured out how to handle this project. And this is had approximately a total time of 2 weeks to design the application. Of course, I'm not saying that in 2 weeks we have done. So it was very hard to get into the lab to do experiments. At that time, we were completely in lockdown. So I had to ask special permissions to the head of my department to go in the lab to work on that. And of course, there were also a lot of delivery delays of materials. So we have been asking for a lot of materials to be shipped to our lab, but there were absolutely a lot of delivering issues at that time. So we ended we completed the last test before, so with the fine tuning of the parameters, actually at the end of May. So we had a total running time of more or less 2 months, but actually we could have done all the project in 2 weeks with one full-time equivalent personnel. So more or less 50%, which is the one on the right-hand side, has been run at home. So with a virtual prototyping software, and everything that has been done with the design of the toolings, with the offline programming of the robot. And then more or less 50% was actually performed in the lab with some pre-commissioning and some fine-tuning of the parameters just to speed up the test. So as a result, we actually get an increased throughput from 288 patients per day, or sample, sorry, per hour. So from 288 to 480 samples per hour, and samples mean actually patients. So plus 66%. So we kind of almost doubled the throughput. Not exactly doubled because there are some waiting time of the robot or waiting time to the human because they are not actually occupied 100% of the time. We are actually relieving the technician from performing 2,200 more or less thumb actions per hour to 840. So we have a reduction of 62% of the thumb activities for the technician. And where is this solution affordable? Well, surely for small hospitals. So what we've seen in the beginning, very large hospitals have already 100% automation of liquid handling. but it is not reasonable for small cities to go to large hospitals, which are typically in bigger cities, to send their samples to be processed. That is increasing the delay of testing, and this is not reasonable. So if you are living in a small town, you must have the test in a reasonable amount of time. And this typically happens, it is not typically happening because there are small hospitals there and everything is done by hand. So having a shorter setup time for this test and having affordable solution also for small hospitals, I think that is the major advantages, one of the major advantages of this application. So small hospitals do not have to send their samples to big cities where they have large infrastructures for testing. They can use this technology to speed up, to increase the throughput, but also to decrease the demand to technicians in terms of times action that are actually quite expensive in terms of musculoskeletal effort. So this is actually concluding my talk. I would like to thank Dr. Federica Facciotti, she's an immunologist at the European Institute of Oncology, which is the hospital where started this collaboration. And I hope you have been interested to my talk, and I'm open to questions. Thank you.
Thank you, Andrea. That's a wonderful talk. Very interesting. We have time just for one or two quick questions. One that comes to mind is with this robotic assistance, does the quality of the test change, either improve or decrease because of the automation that you've integrated with it? Yeah, so the test has been proved in a manual condition. It has, I think, 95, 100 specificity, sensitivity. So it's kind of accurate. So it's quite accurate already. On the other hand, the robot is only responsible for washing. So putting some liquid and removing the same liquid. So it is not really an add value activity. It's not actually relevant, but it has to be done. So we do not expect any kind of decrease in performance or specificity or sensitivity of the test because of the automated technology. As a matter of fact, the relevant part is still done manually, which means that we do expect to have more or less, or actually the same result in terms of accuracy of the assay. Mm-hmm. Were there pipette tip changes included with the automation, or is that something that's manually done by the manual operator? Yeah, so you can do that. Probably you can handle a tip change at the end of the day. The reason is that there's no cross-contamination because you are actually washing out everything. What is relevant is already coated to the plastics. So you're not removing that, you're just removing liquid. So it is not really needed to change the pipette tips. You can do that probably at the end of the day. And this can be done manually, but it can be also automatized as well. So it's not really relevant. It's not really difficult to do so. It can be done, but it's not really relevant. So you probably have to do this one per day or twice a day. Mm-hmm. And the last question is, it's a little bit long, so I'll parse it a bit. Could collaborative robotics be utilized to deal with incoming sample, so with potentially contaminated packaging, receipt, removing sample from a vial, from a standardized package, reading barcodes, and potentially loading multiple liquid handling systems? Yeah, so the samples here are not contaminated. So so they have seen that in the serum there's no virus. They are just antibodies, or at least it's very improbable to have the virus within the serum, and that's the reason why they're not doing this test in bio 3 areas, bio 2 areas. Mm-hmm. They're just standard labs with no particular problems of contamination. The robot is not contaminating the test because it is approved to be ISO 5.
So it's perfectly fine to work with it. And the other question was, sorry?
Oh,
Yeah, so it has cameras on the hands, so it is perfectly fine to read barcodes with the robots already, and that's more or less 100% reliable, because it's completely automatic and without any problem of errors. So it is also improving the traceability, and it is reducing the possibility of errors, of course, if everything, with respect to the complete manual application. So definitely, yes. I mean, in this period where we really need to take care of precision, I think that I would go for robotics, at least for automating the parts that can be easily automated as this one.
Great. Well, thank you. That's a terrific talk. And
thank you very much.
Very impressive. Thanks very much for joining us today.
Yeah, thank you.
Thank you. Moving now to our next speaker. We're changing gears a little bit, moving away from molecular diagnostics to more, next two speakers will focus on imaging in the new world of COVID-19 diagnostics and screening. So our next speaker is Dr. Eva van Wiksoort from Therona in the Netherlands. So Dr. van Wiksoort is the co-founder and managing director of Therona, a company focused on bridging the gap between academic developments in medical image analysis and clinical usability by providing intuitive and user-friendly products that includes state-of-the-art deep learning technology to aid medical specialists in their daily tasks. She's overseen the development of 3 MDR-compliant software products developed under ISO 13485 certification for analysis of thoracic CT scans, chest X-rays, and retinal images, and most recently, 2 dedicated AI solutions for X-ray and CT images from COVID-19 patients. The company has made access to the COVID-19 image analysis tools at no charge, which I applaud you for that. Dr. Wiksoort holds a PhD in medical image analysis from Utrecht University Medical Center in the Netherlands. And after postdoc training at UCLA, she became an assistant professor at Radboud University Medical Center, also in the Netherlands, and co-founded Therona in 2014. So very pleased to have her here today to speak on the topic of artificial intelligence to screen for COVID-19 on CT and X-ray images.
Thank you. Thank you for the very long, nice introduction. It takes away my first slide, so that's always good. Let me share my screen.
Great. We see it.
The PowerPoint? Yeah. Okay. Yeah, so in the original title it said screening, and then I realized I won't be talking about screening. I'll explain that. So I'll talk about AI analysis for COVID-19 on CT and X-ray indeed. Well, it was a very nice introduction. So just for the people who don't know Therona, which might be many, indeed we're based in the Netherlands. We were founded in 2014, a spin-off of a university medical center. And the real vision behind it is indeed, there are so many inventions in medical image analysis academically, but they most often don't make it to the clinic or even large research studies. So that was is the goal of our company, to really make sure all these academic findings get actually used. We're so relevant for COVID-19 because our main focus is chest, both CT and X-ray, and next to that we're also building a line on fundus imaging. So actually, why AI for CT and X-ray? How it happened for us is we were sent home in March to work from home, everyone in the Netherlands, and business kind of stopped. We were working in chest analysis. All the patients that normally were screened with our software were also at home and not in hospitals. And we thought, well, what are we gonna do? Rebuild our house, whatever. And then actually already a few days later, these kind of images were popping up in our news. And these are actually images of CT scanners and X-ray machines placed in front of hospitals in the Netherlands to be able to see if people are suspicious of COVID-19 or not, because PCR testing was not widely available and took way too long. And that's when we realized there might be a role for imaging. Normally I would actually now talk about what do you see on the images, why is it such a good idea? But I understood that one of the speakers after me is talking about this, so I don't want to take away that presentation completely. So I hope the message of that talk is, why is imaging actually useful for COVID-19? But we started in March actually with our X-ray product. Of course, we were after China and Italy mostly. So we found a lot of literature about imaging being used to do diagnosis in symptomatic patients when there's no PCR available. So we read that, and then we started making our X-ray product first with the idea that we would screen in low resource settings. So we are very active, for example, in developing countries to screen for tuberculosis, and we thought that's where imaging is going to be useful. But only 1 week later, we realized, hey, also CT imaging is useful, because also in Europe, for example, they're using CT scanners to see of the people with symptoms showing up at the hospital, who actually is suspicious of having COVID-19. What should we do with these people, admit to the hospital or not? So also very shortly after this, guidelines were showing up from radiological societies, what to do with imaging, how to look at images to see how to manage your patients. And even at that time, the WHO didn't advise imaging. They were actually advising against it, but on July, they already said, yes, you can use imaging in symptomatic patients. For example, when there's no PCR available, or the PCR test is negative, but the clinical suspicion is very high, and to manage your patients. For example, in the Netherlands, the guidelines say, based on the load of the lesions in the lung, determine if someone should be sent home and isolate there or be admitted to the hospital. So this, after all this, we decided, okay, we are going to make, based on our products that we have, we're going to make products for COVID. And why? Well, the CT product we envisioned, okay, sure, with CT, radiologists can quite quickly see if someone is suspicious of having COVID-19 or not. But it's new, and there are all these reporting systems out there, and they're in a crisis situation. So we need to help and quickly determine the load of these lesions mostly. So also find these lesions to indicate them, but also exactly quantify how much lesions are in which lobe in the lung. You see in every guideline for radiology, not only look at does a patient have COVID-19, but also how is it distributed among the lungs. And that, of course, is what AI is very capable of doing. And in this way, we can alleviate the burden also for radiologists seeing new things for the first time. AI could indicate the lesions that are of importance and also indicate how much is it. And of course, it can assist in education, because AI can quickly indicate the lesions and people can teach themselves what it looks like. Again, also when we made the product already in April, we said it's not envisioned for screening asymptomatic patients. I think that's anyway not something you would do with CT, but it's really also, if you read the literature, it's really used for symptomatic patients and how to manage the patients. And for our X-ray product, we actually had a very different use case in mind, as I already pointed to a little bit. Since we're very active in screening tuberculosis in developing countries, we thought that's where this has a real use. Of course, their PCR testing is most likely not available, and if it's available, it's expensive. And X-ray screening is happening. We are working with companies that have trucks driving around with X-ray machines in there, so you could add the software next to our TB software and start seeing if people should be isolated or treated if possible. So also there, it's alleviate the burden. It's also making it even possible to triage for COVID-19. Also there, if we sell, because we sell it for free, but sell it to people, we make very clear this is not a screening tool. It's a triage tool to see if people should receive further testing. And contrary to our first in March beliefs, actually the X-ray product is also used widely in developed countries. So many hospitals we work with now do an X-ray first, and if the X-ray is negative, but there are many symptoms, then they go for CT. So I want to tell you about both our products a little bit, how they work and what they do. So our X-ray product is actually a product that's built on top of our product that we have for tuberculosis screening. This is a deep learning based system that actually uses a lot of images. Most of the images don't have annotations on top of them of where are the COVID-19 lesions. It just says this patient is either positive or negative for COVID-19. But also our own analyst indicated a lot of lesions in part of these scans. And we trained deep learning networks to determine a score which says what's the probability that this patient has COVID-19. And next to that, it indicates, and shows a heat map as you see on the right, where did the AI find lesions and how much. So for example, is the lung 10% affected or 20 or 80%? So the software actually has 3 outputs. It looks very nice, but we did an evaluation where we asked 6 radiologists in the Netherlands. They have varying experience, but they're all experienced and all chest radiologists to also read these scans and indicate if someone has COVID-19 or not and what they think the percentage is. And the software actually performs at the same level as these radiologists. So that X-ray itself is not so sensitive as CT, but the software is as good as humans. So especially for the first use we had in mind in developing countries where there is anyway no radiologist to read the X-rays, we thought this was a very good evaluation. So we put it out there immediately as a research tool, but also went for CE certification, which we obtained in June. Luckily also in Europe, there's like fast tracks for these things. And we offer it for free, indeed, in the fight against the pandemic. So we put the solution in the cloud with AWS. And also because we are working for developing countries, we have an offline solution that we put in the trucks. Cloud solutions are easier, but there's usually no internet in remote settings. And to allow integration really into the workflow of the radiologists, we're integrating with the large OEMs and marketplaces. So these are some examples. For me, my screen is in front of it, but this is an example of one X-ray. And our software says the COVID score is 65, which means 65% chance of a positive case. And 35% of the lung is actually affected. And this is a scan with virtually no abnormalities. It also gets a very low score and it has no affected lung area. So this software to run takes about 30 seconds at most. It depends a little bit on the upload to the cloud actually. So within 30 seconds, this result is on the screen of the radiologist. The software is actually now used in 75 hospitals across 30 countries. And up until last week, we were over 12,000 X-rays analyzed. And well, as we all know, we're in a second wave. So we really had a bit more quiet summer and now there's a huge uptake again of the software. And then the CT product. So also for CT, we have our usual product, which is used, for example, COPD, asthma, interstitial lung disease. And we built on top of this product, the product for COVID-19. So we basically use our existing product, which is also a deep learning based product, as a pre-trained network and added 500 scans of patients with COVID-19 to the training. And these scans were like very rapidly annotated, because there we really annotated every visual lesion before we could train the system. So in 2 weeks, our analyst annotated 500 scans and they were checked by a radiologist. And we were able to train a system that indicates what are the lesions that are suspected for COVID-19. And underlying from our original product, there's a lower segmentation. So we can also really tell where in the lungs are the lesions present. And that, at least from the user experience we asked, is very important because that's what the radiologists base their treatment decisions on. So the CT product does not give a score with a probability for COVID. The next version will, but that was actually a time pressure thing, but also where we added the most value here for the radiologist is really in quantifying the lesions. It's much more work for them to say how much and where, and actually they are under pressure and it's new. And they said, we really have to decide here based on reading this scan quickly, what is going to be the first management of the patient. Isolate at home, admit to the hospital or immediately treatment. And there they really were happy that we basically filled in the form for them, the form of the guidelines they were following. Also here, we did quite a big evaluation before we put it out. So we asked 8 radiologists from the Netherlands, with also up 5 to 27 years of experience to also score the scans for the same aspects. So to say what's the load of these lesions in each lobe of the lung. And again, we saw that the software has good agreement to basically be a radiologist. So that's when we put it out there. And also at the same time, we went for CE certification and obtained it in June. And with the CT software, we also went for to the FDA. And it's not officially cleared, but for the duration of this health emergency, this product can also be used clinically in US. This product takes a little bit longer than the X-ray product. The CT product, when you upload it to our own cloud, including the upload, takes about 5 minutes. So after the CT is taken, 5 minutes later, the result is present. Also here, of course, we have our own cloud solution, but we have integrated with another company, Smart Reporting, and that's really a company that does the reporting for the radiologist. So instead of a radiologist having to read the scan and like write a report or talk a report, they really fill in the report with the numbers from our software. That is actually connected to 10,000 radiologists worldwide at the moment. So it has a huge reach. And again, we're also integrating with OEMs and marketplaces. So this is a bit of an overview of what's happening in the CT software. So once the scan is sent to our AWS upload, there's first a quality assurance. It just makes sure that we're actually looking at a CT scan. You might be amazed of how many, for example, brain scans we get uploaded. That really doesn't work. And then there are actually 3 deep learning networks. One is for segmenting the lobes, because we really have to say in which lobe, how much lesion. Then a COVID-19 analysis network, and one for emphysema analysis. We actually added emphysema. It's from the original product because it's one of the important comorbidities of COVID-19. So patients who also have a lot of emphysema, of course, have much less functional lung. So they're more likely to need treatment, or they might be admitted to the hospital earlier than someone who doesn't have this underlying disease. And the output of the software is, next to all the segmentation, actually a report that fills in the guideline that you indicate. So this is, I think, the Dutch guideline in the example report, but we implemented all the different aspects that are in the guideline that radiologists have to report. Because AI on imaging is very useful, but also very often it just adds an extra image to read for the radiologist. So if you would only show the radiologist, hey, here are your lesions and this is how much it is, they actually have to do something extra to incorporate it. But if we fill in really exactly the structure they have to do for reporting to the treating physicians, then we take work out of their hands. So these are also some examples. We used, for the examples, we used public cases. So for example, here you see a case with quite some lesions in the lung, especially in the middle part of the lungs. And you see different colors on the lobar severity, and that indicates in which lobe has the lesion been found. And then on the left is the table that the radiologists really need to fill in. So there's a severity score overall between 0 and 25, and affected area, but most important, for each lobe, it also gives the severity score and the affected area. So in different guidelines, they use either the severity score or the affected area and the number of lobes to say, what should we do with this patient? So if you use, this is a scan of someone with virtually no lesions. So you also see that most of the lung just gets no annotations and only the lesions are found. So this is really a tool to quickly help the radiologist to see what's going on and how severe is it. And that's most difficult for humans to do. I think that's why the CT product gets such positive feedback, is that you're really taking out of their hands what they're not capable of doing. They are capable of quickly seeing, hey, there are lesions, it's probably COVID-19 or not, but how bad is it? That's something they really like to just have quantified. So the CT product, these are numbers only from our own AWS solution, so not from any integration with any partner. We run it currently in 47 hospitals in over 15 countries, and 4,300 scans to date have been analyzed. We see a huge uptake in the CT at the moment. So I think already now we're half of November, we have done more scans than in October. So it's unfortunately, but it's taking up. So I always like to say, yes, we do very nice work, but of course we're not alone in recognizing that imaging and AI can really help in the pandemic. Of course, in research, there's a lot of work. It's too much for me. Well, I don't even read it all, but it's also too much to iterate. But there are also some nice overview papers already, like the one I show here. I think in research, a bit of the downside is that many things that are proven for a single center, the center the researchers work in. But I think it's very good that the message is the same in every paper you read. It works very well. It needs some work to distinguish better between before COVID and after. We also know that of the product, people with normal pneumonia are often picked up in the first version, of course. But in general, in a symptomatic patient, it's a very good tool to quickly assess what's going on. And there are also some other companies that put out, especially CT products. I think very important. Yes, we put out a product very quickly. We are still offering it for free at the moment. We will, as long as there's a pandemic. Luckily, there are some other companies, of course, also supporting us. So, for example, AWS is supporting us in making it available. So that at least we're a small company, but we don't take this alone. We're now working on the second version, where we have a lot more data. Most hospitals that use the software are so enthusiastic that they're also sharing a lot of data and annotating for us. So we can do much better at COVID versus any scan that's from before COVID, basically, where we sometimes pick up lesions. We also are doing a lot of research to say, yes, imaging is very sensitive, but we have seen several papers, if you include blood markers, you can get better, especially in more subtle cases. And that's mostly for the X-ray product, that X-ray itself has not the best sensitivity. If we add blood markers to the system, then we go almost to the sensitivity of CT. With the CT, we're looking a lot at, can we from the first CT predict who is going to get worse or who can recover at home? That's really more research we do with our most closest partners. And also we're looking at, for trials, we're looking at people with the lung damage that's left after COVID, can we help out? And then actually, yeah, we are now doing a lot of work getting this product everywhere, integrated, accessible to all the radiologists. So we think it's important to make it durable so that for a next pandemic, we don't have to, we as a society, not us, have to do like the implementation in the first wave and then have it available in the second one. No, just leave it there, make it a sleeper system, run it in the background, be able to update the models so that if there's a new pandemic in the first week, we can do this kind of screening instead of in the second wave. I think that's what we're aiming for as a community, I would say. Thank you.
Thank you. Well, it's very impressive. Very impressive. So there's a few questions we have. This person says this is very exciting. I agree. Can you share if there have been any FDA regulatory challenges due to the AI-based nature of the algorithm? And is there a clear regulatory path for these types of algorithms? It's a good question.
Yes, it's a very good question. No, the luck we had is that we have a lung AI-based lung product, 510K cleared. Of course, that was a much longer path. And now for the emergency clearance, or not clearance, I have to say allowance, it's only for the CT product, and it's based on the fact that we do have 510K clearance, and this is an addition to that product. It's really only allowed for use during the pandemic, and in the meantime, we will add it to our 510K. But yes, it's a very good question that I could talk about for hours. But in principle, with the FDA, also this went very smoothly.
Another question is on the severity score. How is that calculated? Because you mentioned that that's something that radiologists can't do on their own, but it's calculated in software. So how is that calculated and on what basis?
Yeah, so actually the severity score is officially very simple. It's a threshold on the percentages. Why do we give both? Because we also had 8 radiologists first score the percentages visually, and then we showed them manual annotations that were made by our analysts and asked them if they were correct. And all of them said that the annotations are correct, but their percentages were very different, also from each other, but also from what you compute, and that's because 3D thinking is very difficult. For humans, they see a large area affected and don't take into account the rest of the volume. So that's why we give both. But if you, like also, if you, it's just a threshold on the percentages.
Mm-hmm.
So I think, I don't know by heart, but usually 0 to 20, 20 to 40, something like that.
Mm-hmm. And last question on the operator curve, you showed originally to validate the software that used 6 individuals and their their expertise. Now that you have literally like thousands of radiologists using this now, has that changed the operator characteristic curve, and are you seeing an improvement in sensitivity, specificity, or is that pretty much holding up what you had originally benchmarked?
So we are actually doing a very large study now, indeed, with our users. We haven't done it quantitatively yet. So we're doing post-market clinical follow-up right now. So before this, we've only done user experience questions. We know that the software is being improved right now also for simple things like if it's a different scanner, it does hold up, but it can be better. So
Right, well, this is wonderful.
We'll publish it once we know.
That's why we'll look forward to that. Thanks very much, Eva. That was a very inspiring talk. And our next speaker, along the same lines, in the topic of radiology as applied to COVID-19, is Dr. Jeffrey Kahn from the University of Wisconsin School of Medicine. So Dr. Kahn is a professor of radiology, chief of thoracic imaging, and vice chair of quality at the University of Wisconsin School of Medicine. He specializes in thoracic radiology with special expertise in interstitial and diffuse lung diseases, lung infections, and high-resolution CT of the chest. Dr. Kahn is an NIOSH certified B reader with expertise in occupational lung diseases, has authored or co-authored over 100 articles in radiology, in addition to multiple chapters and textbooks on thoracic imaging, is a regular lecturer on topics in thoracic imaging at national and international conferences, and in courses organized through the American College of Radiology, the American College of Chest Physicians, and the American Thoracic Society. So we're very pleased to have Dr. Kahn here today with us. And the title of his talk is COVID-19 Imaging Considerations.
Well, thank you, Colin, for the invitation and the opportunity to speak. So I'm going to focus on a clinical approach sort of to how we have used imaging in the pandemic, and particularly on radiography and chest CT. So I like to always start with this slide. These are 4 different patients with 4 different diseases, and which one of them has COVID-19. And we'll come back to this at the end. But there is some commonality that I'll talk about in this when we come back to the answer. So at the outside of the pandemic, a bunch of radiology groups and other medical groups got together and put out statements rather early about the role of imaging, including the Society of Thoracic Radiology, the American College of Radiology, the Radiologic Society of North America, and then the Fleischner Society, which is a multidisciplinary international group consisting of pulmonologists or respirologists, radiologists, pathologists, and other scientists who have dedicated their careers to imaging the lung and lung disease. And the initial work from China relied heavily on CT and using CT as a screening modality for COVID-19. Very little was understood at the time. The testing available was quite limited, and it was thought that the PCR wasn't particularly accurate. So many of the early papers we first saw showed a high use of CT, both at screening, but as well as serial CT imaging during hospitalization. Now, our practice in the US has been quite different. All of these societies came forth and did not recommend CT screening because the findings on CT frequently overlap those with other lung injuries. Primarily influenza, which of course in March was at peak in the United States, as well as drug toxicities from chemotherapy, immunotherapy, and even autoimmune disease. And there was concern about contaminating CT suites, tying up scanners so that we couldn't treat our other patients, trauma patients, for example. So these organizations really came out pretty strongly against that. So at the time, we had to consider the following: the available published data, which is far less than we have now, risk to patients and healthcare workers. There was concern about shortage of PPE. We didn't know how the virus transmitted all that well, and we wanted to make sure we didn't contaminate our rooms, as I said, or expose other people in the hospital. We also had to consider access to RT-PCR. Some institutions were able to ramp up their testing capabilities while others were not. Also, the supply of PPE. Early on, we had shortage of PPE, both N95 masks, just barrier protection, and other types of equipment. So we wanted to limit the contact with patients or patients suspected of having COVID-19. We had to discuss and consider the role of imaging in patient care. How do we change management? That's one of the questions we always ask in medicine, is if we're going to do a diagnostic test, is it going to change what we do for the patient? Of course, there's no cure for COVID-19, and if you have a lab test that establishes the diagnosis, is imaging going to change how we care for that patient? And then, of course, at the time, we have seasonal respiratory illnesses, influenza in the spring, and now we are coming on our flu season again in the Northern Hemisphere, and there's concern again that there's overlapping both clinical but also imaging appearances. So the World Health Organization, in their diagnostic criteria, specifically at the time, left out any mention of imaging. They're based on symptoms, and of course, a confirmed case is with laboratory confirmation. You cannot confirm nor exclude a diagnosis of COVID-19 with imaging alone. So I worked with the Fleischner Society, and we put together a document, and we published this in 2 journals as a statement. And I'm going to go over the different scenarios we came up with. But the following statements came out of this paper. Imaging is not indicated in patients with suspected COVID-19 and mild clinical features unless they are at risk for disease progression. Now, this would include patients with coexisting conditions like diabetes, chronic lung disease, maybe obesity. But for otherwise a younger and healthy person, we probably wouldn't recommend any imaging at all. And as a matter of fact, when New York City had its first surge in the late spring of 2020, only the sickest patients were even brought to hospital. So most of the mildest patients stayed at home and never got any evaluation, probably didn't even get tested. And it was only the sickest ones at the time that really got imaged. And we also said that imaging is only indicated in a patient with COVID-19 and a worsening respiratory status. So if you have a patient who's admitted to hospital, has COVID-19, but is otherwise stable, there's really no medically sound reason to image them routinely. It doesn't change management, it uses resources, and of course exposes personnel and potentially other patients to an infected patient. But we did add the caveat that if you are in a resource-constrained environment, and we didn't define that specifically, but this may be a shortage of PPE, maybe lack of access to testing, we did suggest you could use imaging for medical triage. And this was done in the early surge in Italy as well, where there was a limit on testing as well as PPE, and they did use predominantly chest X-ray to triage patients for hospitalization or for isolation. So in those environments, imaging may be helpful, but it only works when you have a high pretest probability of disease. So in where I am now, for example, in Wisconsin, we have some of the highest rates in the United States. So the pretest probability of a patient with a respiratory illness coming into my hospital having COVID-19 is quite high. But back in March of 2020, we had very few cases, maybe on the single digits in our county of 500,000 people on a daily basis. So the pretest probability would be very low, and we were much more likely to be seeing a patient with influenza or another respiratory illness rather than COVID-19. So with the Fleischner Society, we came up with these following scenarios. So scenario 1 was a patient presenting with mild features consistent with COVID-19, maybe a low-grade fever, a cough, but not shortness of breath or low blood pressure or something like that. And we said any pretest probability of COVID-19. So it could be in New York City where the pretest probability was high, or it could be in the rural United States in March of 2020 where very few cases or no cases were being reported. And we said no significant resource constraints. And so if testing is unavailable, the first step is, of course, if it's positive, then you look at risk factors. And only if the patient is at risk for progression because of age or pre-existing conditions would imaging be indicated. And this typically gives the doctors a sense of how badly affected the lungs are. Not in isolation, but also with laboratory testing of the blood, oxygen saturation in the lungs. But imaging can also show the extent of lung injury. And then if the patient continues to remain stable, no further imaging is indicated. If patients didn't have risk factors for progression, we recommended not imaging at all. And only if they became worse, then imaging would be indicated. However, if the test was negative, there's no reason to image the patient. We know you can have a false negative test, but the likelihood that the patient, the imaging is going to be helpful in further management is very small. Now, if you don't have testing available, you can still use imaging only if patients have high risk for progression of disease because of risk factors. But in an otherwise healthy young person, again, even without testing, we did not recommend imaging. And we followed this paradigm across the different scenarios. So in the second scenario, we had our sicker patients, moderate to severe features. So these may be patients with low blood pressure, patients requiring supplemental oxygen, patients who are in respiratory distress. Same caveats with no any pretest probability and no resource constraints. And in this case, if their test was positive, we recommended imaging, and only as a baseline, and only further imaging if the patient worsened. But if the patient was stable or slowly improved, no further imaging was recommended. If the test was negative or unavailable, we also recommended imaging in these patients, primarily to look for an alternative diagnosis, such as heart failure, community-acquired bacterial pneumonia, and maybe a drug toxicity or something like that. However, if the imaging showed features that would be consistent or compatible with COVID-19, we recommended a further test, whether it was a repeat PCR or other type of testing. In the final scenario we put together, we had, again, sicker patients with areas of high pretest probability. So this, at the time of March, would have been New York City, Italy, still parts of China. Right now, this would be all over Europe, or most of Europe, and most of the United States, where cases have really increased in just the past month or so. But this also applies to areas that are resource constrained. And so this could be hospitals running out of PPE, running out of beds, not enough access to testing. So the first question we brought is rapid COVID testing available. And rapid may vary from 15 minutes to maybe just a couple of hours. Some tests with large centralized labs could take 24 to 48 hours to get results, which isn't particularly helpful when you're trying to triage patients. So if rapid testing was available, we only recommended imaging if it were positive. If rapid testing is not available, we did suggest imaging as a potential triage tool. If there was an alternative diagnosis, it would be treated as such with the pre-existing management of, say, heart failure. But if it suggested COVID-19, we did suggest medical triage. And this is where you would decide, does a patient need to be treated in a hospital, an alternative care facility, or the patient is safe to go home. So that's what we came up with. And this, again, was done in the late spring of 2020 based on what was published at the time. And we have not revised these recommendations. So when we recommended imaging, we didn't specify whether we should use a chest radiograph or CT. And for a variety of reasons, we didn't have a lot of data, and there are a lot of differences in local and regional practice patterns. So radiography is a relatively inexpensive modality. It varies from where you practice, what the costs are, but relative to other diagnostic imaging tests, it's quite inexpensive. It can be done rather quickly in a matter of minutes. Most importantly, I think it can be done at the bedside. We can bring the imaging apparatus to the patient. So if we have a patient in isolation, we have a patient in the emergency department, we don't need to transport them through a hospital, potentially exposing others to that patient. And it's fairly quick to clean up. It doesn't require cleaning an entire room, just the equipment itself. The cons of radiography, though, is it has a low sensitivity and a low specificity for most things, not just COVID-19. Partially because if it's done at the bedside, we only get one view. So we take a frontal view. So our evaluation of the anatomy is limited. And we rely on the contrast resolution of radiography, which is much lower than that of computed tomography, although it still has a fairly high spatial resolution. The other problem is the low specificity, in which case many findings overlap. So distinguishing community-acquired pneumonia from, say, COVID can be challenging, or other causes of lung disease. So just some examples, kind of the spectrum of COVID-19. And this is a patient in our emergency department presenting. This is a bedside frontal radiograph. And the findings are quite subtle. I've put arrows on them because I know many of you are not physicians or radiologists. But this was a patient with COVID-19 who had some of these early peripheral rounded opacities. And this has been described pretty detailed in the literature. The early papers from China also describe this. And this is the very beginning of the lung injury. And so what we're seeing on imaging is the lung's response to the injury. And I did see a couple of questions in the chat beforehand about patterns or pathognomonic findings. And I'll try to talk about that a little bit. This is another patient here, and this patient has, you can see, more extensive disease. There's more opacities, but they predominantly occur in the periphery of the lung, at least initially, in most patients. And this is our very typical appearance. It's not specific for COVID, but in the setting of a high pretest probability, when a patient with a radiograph like this presents to my emergency department, the likely diagnosis at this time is COVID-19. Now, before the pandemic, if I saw this in the winter, this would be influenza. Or if this is coming from my cancer clinic, this would be a drug reaction to chemotherapy or immunotherapy. This patient had far more extensive disease. You can see quite a bit of peripheral patchy opacity. So the white patchy stuff is the abnormal lung. The more central lung, the blacker looking lung, is the normal lung. And then this patient had a very unusual distribution. Rather than being peripheral, it is more central to the middle of the chest. And when we refer to peripheral versus central, when we're talking about the lungs, it's relative to where the airways and the vessels enter the lungs from the central portion of the chest. So this would be a central pattern. So this is not typical of COVID, but has been described. And then finally, this patient has very severe disease. You can imagine this patient is in quite distress. This is external tubing here from a mask. This patient's receiving high flow oxygen, about 15 liters per minute through a mask, and has extensive white stuff in the lungs. So these are the patients that are at highest risk for requiring mechanical ventilation or intensive care. But you have to remember, this patient also had COVID-19, and this is a normal portable or bedside chest radiograph. So normal imaging does not exclude the diagnosis. So we cannot use imaging as a yes/no tool. But again, if you have a typical appearance in the right setting with the right pretest probability or prevalence in the community, it can be helpful, especially if you have limited testing resources. We did undertake some safety measures, and a lot of this was developed during the Ebola outbreak at many institutions in the US. And this is a technique we call through the glass. And this is one of our senior technologists taking the chest radiograph or setting one up rather than being in the room with the patient through the glass door. Because the X-ray beams, of course, can penetrate unleaded glass without any problem. And so we worked with our medical physicists to fine-tune the technique, and we were able then to take our X-rays with our technologists standing here outside the patient room. Here is our X-ray unit. There's the patient room in there. And the nurse who was already in there with the patient in full protective equipment would be able to place the detector. It's a solid-state detector that goes behind the patient and then is able to transmit the image data back to the machine to generate the image. And this reduced reduced our use of PPE. In this case, we just have a basic mask and a face shield here. We don't require the full gear or N95 masks. Now, what about computed tomography? Because there's been a lot of work done with computed tomography with artificial intelligence, but also in just clinical practice. Well, CT is more sensitive and specific for all lung diseases, and it's very good at finding alternative diagnoses, better so than chest radiography. The problem is it is relatively expensive, anywhere from 10 to 20 times the cost of a chest radiograph. The radiation dose is about 10 to 30 times higher. It takes longer to do a CT scan, both getting the patient on the table, setting up the scan, acquiring the scan, which is only about 4 or 5 seconds, and then transporting the patient back up. And there's a much longer cleanup for a CT suite because you have to clean the entire room, exchange the air, and wipe more surfaces down. And so it's not practical if you're dealing with many, many patients coming in all at once. So this is an image from China here, and this just shows that you can see the protective gear, and all these surfaces have to be wiped down. Here's the CT scanner. This is the contrast injection apparatus, which we typically wouldn't use for COVID, but if we were concerned about certain indications, we might. And again, this would all have to be cleaned. And then the air inside this room would have to be exchanged, unless you have a negative pressure room. Another group that I worked with was the Radiologic Society of North America. And we came up with some standardized reporting language around COVID-19 to try to make it easier for radiologists out in our community, both in academic centers, but also in community practices, to provide useful information to our clinicians who are ordering chest CTs, and also to provide standard reporting that may be used later in research, both for artificial intelligence and other types of studies. And we came up with these categories of COVID-19, the typical, indeterminate, atypical appearances, and negative, with some specific radiologic findings and some suggested reporting language, including some tags that could be used for research later. And I'll just go through a couple of these. So this is a typical appearance that we see with COVID-19. And this is a pattern we call organizing pneumonia. The lung can respond to an insult in only a handful of ways, and any pathologist listening will recognize that as well. And this pattern is one of the more common ones we see. It's not always from infection, even though it has the word pneumonia. It's not necessarily an infection. As a matter of fact, I see this in my oncology practice on almost a daily basis on patients who are on immunotherapy, which has become a common part of oncologic practice these days. It's a very normal response in the lung. It frequently accompanies infection, as I said, drug, autoimmune disease, and it can be self-limiting once the insult is removed. However, in some patients, the injury continues despite removing the insult and can actually lead to scarring of the lung. And this is what we're seeing in COVID patients who recover. Many of them who have symptoms that persist despite having negative testing, whether it's shortness of breath, cough, or altered pulmonary function testing, may have some scarring left in their lungs. We've even seen some patients with such severe injury, they've required lung transplant. And so this organizing pneumonia pattern is a clue that the lung is trying to respond to the virus's injury. And it's characterized by these peripheral opacities that range from what we call ground glass, this hazy opacity, to consolidation, which is the denser white patchy opacities that I put these yellow arrows on. So this is the kind of stuff I'm looking for as a radiologist. And when someone is suspecting COVID, this is highly suggestive of it. This is just a more severe case showing that peripheral predominant opacity in this organizing pneumonia pattern. This is a coronal view, so this is reconstructed from the data as if you're looking at the patient as opposed to a cross-section from the standing at the patient's feet. And we can see that strikingly peripheral predominance, and some authors have described a basal predominance as well. This is an earlier manifestation. This is from a colleague of mine in New York City, and this was a patient with, I think, was asymptomatic, and this was from China where the scan was done, and you can see these rounded opacities. This is some of the earliest lesions we see with organizing pneumonia. It's not specific to COVID, but again, when you're dealing with a high pretest probability, even in an asymptomatic patient, maybe they're scanned for a different reason. They're being scanned for cancer follow-up, or they're having chest pain, and that's commonly what we see in our emergency department. But they may not have a fever or a cough, that this may be the earliest manifestations. And in this case, it may be warranted to test that patient. Just some more images here showing these rounded opacities. And what we're seeing again is these areas of organization, sort of the host response to the insult. These are two different patients here. So typical appearances, we said these are the commonly reported features of COVID-19, but we did include in there other processes, as ones I've mentioned, can look like this. Now, we also had this indeterminate category, and this one you look at, it kind of this white stuff is sort of everywhere. And this one we see with other things besides just infections. And we sometimes see this when there's too much fluid on the lungs, if a patient's bleeding into their lungs from an autoimmune disease, or say a illicit drug like cocaine can occasionally cause pulmonary hemorrhage, or even smoking marijuana rarely can cause people to bleed into their lungs. We can see this kind of appearance as well. So these were categorized as indeterminate. Here's another example. We have this very asymmetric process. We have larger areas of involvement. We might think sort of reminiscent of some of the earlier cases I showed, but we might see this more with a community-acquired bacterial pneumonia. So we consider this indeterminate as well. And then you have a patient like this with very subtle abnormalities, just the very beginning. Is this just a little bit of lung that's poorly aerated? Is this the residua of a previous infection? So this very minimal involvement we consider indeterminate. And then this patient was one of my patients here. We see this area where it's just one portion of one lung involved. And This is not specific to anything. I mean, this could be a little area of hemorrhage, a little area of fluid, or it could be COVID-19. This was COVID-19, but it was an unusual case in that it only involved one portion of one lung. Probably we just imaged the patient very early in the disease course. So in the wording here, we said, we included I stress processes that can occur with a variety of infectious and non-infectious processes. Very vague language here, but it's because it's a vague appearance on the CT as well. And then we had this atypical appearance. So this was a case shared with by a friend of mine in Michigan. This is typically what we see with community-acquired bacterial pneumonia, the one we typically think about when we say a patient has pneumonia. It's usually one area of this dense consolidation affecting one lobe of the lung. And these are usually bacteria, not viruses. Occasionally we'll see this with some endemic fungi in North America, but very unusual for COVID-19. And as a matter of fact, if a patient had a positive test for COVID, I'd be concerned they had a secondary bacterial infection if I saw this. We would need to definitely evaluate the patient for that. And then this patient has these tiny nodules here, and these are centered on the small airways of the lungs or the bronchioles. And that has not been described as a manifestation of COVID. And this came from a friend of mine in Seattle during their peak. And so this was more likely an infection of the small airways from another organism, or the patient aspirated in which oral secretions or gastric secretions are accidentally inhaled into the airways and get into the lungs and can cause inflammation there. So something like this would make us think about a different disease process. So we stressed here, alternative diagnoses should be considered. And then again, negative for pneumonia. This is a normal CT, but this patient has COVID-19. So imaging does not exclude the diagnosis. That's, I think, important to stress. So how well did these patterns perform? Well, a group in Canada actually studied these categories retrospectively. They had radiologists with different degrees of experience with chest CT. And what you can see here is the inter-observer agreement for the typical, the atypical, and the negative or normal patterns is extremely good. It's almost perfect. These are excellent numbers if you get these kind of kappa values. The indeterminate was actually quite good, not as good as the other ones. And that's because there's so much overlap with the typical and atypical that you could imagine someone less experienced may be inclined to call it atypical than someone with more experience. But overall, these categories performed fairly well. And as a matter of fact, there's a bunch of different classification systems that have been put forth. We heard a couple reference to the CORADS, which was developed in the Netherlands, and then these other ones. This was in California, this was in Asia, and this was in the UK. So they all have some overlap. Some of them are more elaborate, but when you put them side by side, there's a lot of similarities. But to my knowledge, they have not been compared one to the other. A couple of papers that have been published also showed that a normal chest CT does not exclude the diagnosis of COVID-19. This is what we would call a false negative study if we're relying on CT as the standard, or I'm sorry, as the test. And then just another one that all patients should be confirmed by RT-PCR. So there are limitations, and as I mentioned, there is overlap with influenza, drug toxicities, autoimmune disease, and vaping-induced lung injury, which we had in the US started about a year ago. And interestingly, in my practice, we had 4 cases of vaping-associated lung injury that started after the pandemic, usually in April and May, even though the US Centers for Disease Control and Prevention stopped recording cases in February of 2020. And we've seen this in larger studies as well. Up to 15 or 20% of vaping cases have occurred after the pandemic. So patients coming in looking like COVID, it's still important to ask if they have been vaping, because we've seen, although fewer cases, we still have seen some. So back to my patients again, which one has COVID? These are all organizing pneumonia patterns. So any one of these could be compatible with COVID. But in this case, this patient was getting chemotherapy with bleomycin, which is notorious for causing lung injury. This patient was a vaping injury, had more severe injury. This patient actually had influenza with those peripheral rounded opacities. And then this patient had COVID-19. So in summary, the role of imaging depends on your clinical presentation. We need to consider local resources and disease prevalence, which of course is very high right now in the US and Europe in particular. And then guidelines and recommendations are going to continue to evolve as the pandemic does, as we get more access to testing, better testing, and a better understanding of the virus. Thank you for your attention.
Thanks, Jeff. Wow, that's very interesting. I then really fully appreciated how subtle the images are and how challenging they can be to interpret. So that was really super interesting. So we have a few questions. Actually, a few questions came in after Eva's talk, so it kind of overlaps with yours, Jeff. And I think, I'm not sure if you answered this, but one question was about asymptomatic individuals that are asymptomatic relative to COVID-19. And does the CT or an X-ray scan, does that help in diagnosing COVID-19 if someone's asymptomatic?
Well, we have seen cases of patients with no symptoms that we find abnormalities on their CT done for a different reason. Maybe they have abdominal pain, and we get a little bit of the lung bases when we do an abdominal CT, and we find abnormalities that raise the question of COVID. So we've been recommending they get tested, and we have found a few cases of patients, but it may be that their symptoms were their abdominal pain, so it's unclear. But we still do not recommend screening patients with imaging for if they're asymptomatic.
Mm-hmm. Another question is how to differentiate COVID-19 CT manifestations from other viral influenza, since there are overlaps of manifestations. I think you may have addressed that, but
I did mention it. Yes, there's significant overlap because in my experience, it's the same pattern of lung injury. It's this organizing pneumonia pattern in most patients. The patients with more severe disease develop what's called diffuse alveolar damage. It's a severe injury to the lining of the lungs. And those are many of the patients who have rapid decline. And that can also happen with influenza. And that is responsible for many of the influenza deaths. So these severe lung injuries. So as I said, the lung only responds in so many ways. Now, certain viruses have a predilection for the airways. Things like respiratory syncytial virus, which we think about with wheezing babies and usually causes milder disease in adults. But so based on what I've seen and read, COVID and influenza overlap almost identically. I don't think we can tell them apart.
Interesting. And the final question is lung damage typically from endothelium damage, or is it from damage to bronchioles? And if so, is there any way to differentiate?
That's a great question. The typical injury we see is primarily to the epithelium of the lung and occasionally the endothelium, and that results in scarring. To my knowledge, there's not a lot of data that shows there's small airway, the bronchiole injury. We could do pulmonary function testing later on, and if they show an obstructive component to their physiology, that would favor an airway injury versus if it was restrictive, meaning that the lungs aren't expanding as well and emptying as well, then you would have more scarring. But I have not seen patients with a lot of small airway involvement afterwards. The ones I've seen either with severe disease, we've even transplanted a few, have all had severe scarring. So I think that's more of an epithelial injury.
Interesting. Wow. Great. Well, this is wonderful, Jeff. Thanks very much for taking time to tell us about your work in this area. It's absolutely fascinating. I'm really glad that we see advancement both from your work and Eva's work on the radiology front. So thank you again for joining us today.
Thank you for the invitation.
You're welcome. And so our last speaker for today was to be Steve Schachter, but unfortunately he had a family emergency, and Dr. Gagliano has graciously accepted to stand in for him. And in that, both Steve and Nancy Work are heading up our key players in the NIH RADx program. So you heard Dr. Gagliano's presentation earlier this morning, and now the presentation today is really on the new paradigm for medical tech development. So it's going to be quite an interesting presentation, I'm sure. And Nancy, are you ready to share your screen? Everybody knows Nancy from this morning, so I won't have to reintroduce her.
Yes, and I will try to do a better job sharing screen. So I'm not going to say anything until I share and confirm with everybody that you actually can see my screen.
Yes. Wonderful.
Okay.
Perfect.
We're good. So good afternoon, everybody. I guess I'm a bit of a bookend. So I'm going to talk about the RADx program, the Rapid Acceleration of Diagnostics program that I have been incredibly fortunate to participate in. Steve does indeed send his apologies for not being able to join us this afternoon. Basically, I'm going to go through the background of the organization before RADx started, and then share with you the structure and the purpose of the RADx program. So this all starts with CIMMIT, which is the Consortia for Improving Medicine with Innovation and Technology. Originally started in Harvard and MGH. I was involved with the organization in the 90s, which is how I've stayed with this organization and involved in RADx. And essentially the core concept was, the mission was to take innovation, to take exciting developments, to actually take engineering concepts and other concepts and bring it into medicine for the advancement of medicine and improve patient care. And in the early days, it was really fun to have a variety of different types of experts working with us to really think creatively about how we can incorporate those concepts in healthcare. And in the early days that I was involved, a lot of it was actually around process improvement, which when dollars were flush and medicine was very much based on kind of a apprenticeship model, process improvement was not very well known in healthcare. And then as quality metrics started coming out and dollars got shorter, a lot of these concepts were brought into healthcare. And then around 2012, POCTERN was started, the Point of Care Technology Research Network, and broadened the infrastructure of CIMMIT into a number of other academic organizations. The Emory and Georgia Tech and their organization called ACME, focusing on engineering technologies and a lot of the science behind it. CAPCAT, focused predominantly on heart and lung and blood and sleep disorders, and they are based at UMass Lowell. And then Northwestern brought in their team, and they've been internationally focused on technologies in low income areas. For example, they do a tremendous amount of work in Africa. And last but not least is a group from Johns Hopkins that focus on point of care technology with a specific focus on sexually transmitted diseases, but broader than just sexually transmitted diseases. And CIMMIT functioned very much as a coordinating center for POCTERN. So now we get into COVID, and you may or may not be aware that Senators Alexander and Blunt did a post-op in early April saying, we need more testing, and we should launch a Shark Tank approach to developing tests and getting them out into the marketplace. So who better than that but CIMMIT? So under the extraordinary leadership of Francis Collins, the NIH director, and Bruce Tromberg, the NIBIB director, who had already had a connection with CIMMIT, CIMMIT brought forth a proposal that we could indeed set up this Shark Tank-like project. And we were awarded essentially two grants, a $500 million grant for RADx Tech and a $230 million grant for RADx ATP, which was all essentially run within the POCTERN core center. So let me give you a sense of what our goals were. So the goals were to increase not only the number of tests, but also the type of tests and who had access to the tests, and really optimize the performance of the tests. So I'm sure you all remember in the early days, there was a lot of concern about the accuracy of the tests that were out, as well as the lack of availability. So on the left-hand side, you will see that we were focused on home-based tests, point-of-care tests, and laboratory tests. And that at that point, when we were launched, there were 250,000 tests a day that were estimated available, and they were almost exclusively within central laboratory type facilities. And it was projected on the right-hand side that if nothing happened, there would be an increase, a modest increase in laboratory tests, probably hitting maybe close to 1.5 million or so tests a day. But with RADx, the goal was to be able to get to a total of 6 million tests a day. And as you see, if we were looking at the innovation potential, there were risks in both new technologies as well as scale up. Could we take a new technology and scale it up? Could we take a new technology and make sure we de-risked it? As well as the goal was to dramatically increase the availability of point of care testing. That's always been a core thought, as well as increase laboratory access. So this is the framework for how we launched the project. Now I'll talk about the group. So leaders from all the different organizations came together to set up the infrastructure that were needed, and we created a national network of over 500 experts, and Colin is one of our experts on the project. We have close to, I would say, about a little less than 100 people working full-time on this project from all of these organizations, and then a number of other folks who are brought in on an as-needed basis to provide advice and support. What I have found incredibly fascinating about this project, number one, on the left-hand side, you will see a variety of acronyms for our government agencies. And we have worked hand in glove with those agencies, and I would say have stretched and pushed them in speed and ways that they have never been stretched and pushed, but they have been phenomenal partners. In the center, you see the academic organizations that have set up and made to be the core of this process, but you also see on top a group named Ventuell, a company named Ventuell, and a company called Biocomex. And through those two, we have an extraordinary list of business-minded IVD specialists, people who have spent their entire careers manufacturing, distributing, focused on the technology behind these diagnostics. So essentially, you have three groups that have not historically worked together: academia, the government, the business and commercial side of diagnostics, all working together to make this happen. So when we launched the project, and this was in April, there was a national call for innovative technologies focused on the diagnostic arena. We had over 3,000 applications initiated and over 700 applications completed. And I think a lot of people didn't complete their applications when they saw how rigorous the project was going to be. Every single completed application was reviewed by our viability panel, a group of experts, to look at whether the science and the infrastructure of the company could have the possibility of producing a viable product. 136 companies then went through the Shark Tank-like process, which was a deep dive process done by a team of about 5 or 6 experts to work directly with these applicants to essentially look under the hood, look at their technology, look at their science, look at their infrastructure, look at their data. And of those, they were then brought to a steering panel of about 15 individuals. Once again, we had manufacturing experts, we had technology experts, we had clinicians, we had scientists on the panel to evaluate whether or not these companies should be funded by the NIH to advance toward solidifying the company and producing. They then went into phase 1. Phase 1 was roughly 4 to 6 weeks long, where they had tremendous resources, not just an initial bolus of money, but access to regulatory research, commercialization research sources, business, technology. I'm going to pause here and say supply chain. Anybody who's involved in the production of diagnostics is aware of the incredible challenges this country is facing with supply chains. I think most people have heard about the swabs as being a supply chain, but we've had reagent problems. We've had manufacturing tip problems. We have, you name it, nitrocellulose for those pregnancy type tests. You name it, we have had challenges in supply chain, and our organization has stood up a supply chain team to work directly with the Department of Defense to get these companies the supplies they needed. They then go through another steering committee process to then go into phase 2, where they are eligible to get even more financial support from the NIH to ultimately bring them to market. And today we have already, and we know this number is going to increase even further, but as of yesterday, our companies were producing an additional 520,000 tests a day, and we are well on our way to get close to the mark that we had laid out for ourselves through this project. And the tests have been really, really varied, which is, I think, exactly what we were hoping for. So you've had the opportunity to talk and hear about a variety of tests, and some of them actually have been through the RADx funnel. And one of our goals was the variety of tests. So far in the end stage, and these are the tests that we can publicly announce. We have 17 nucleic acid tests, 5 viral antigen tests. We have 8 point of care tests, 3 that we kind of call in between, more appropriate for a small healthcare facility, 11 laboratory-based tests. We've supported the regulatory efforts, and I think it's 11 that have already received their emergency use authorization, and we have 3 more that are, let's just say, almost any day now. We expect by the end of December to have 2.5 million tests coming out, and shortly thereafter, many, many more. In the pipeline, as I said, we have 21 additional point of care tests that are coming out. One of them is a breath test that we're very excited about. We're keeping our fingers crossed that will also get all the way through the funnel. It's been an enormous, wonderful, contributory experience, I think, for everybody involved. The company was launched virtually The vast majority of people on the project had never worked together. It's been a fascinating environment in that uniquely we have, although the fact that the cultures are so different, you can imagine what a business culture is like compared to an academic culture, compared to the government culture. And one of the things that I have been so surprised about is how well everybody is getting along and the collaborative nature and how we have all learned from each other as we've done this. Here's a couple of the tests. Some of them you may have heard about, some of them you could look up, but a whole variety of different tests that are actually already out there and being marketed. So we're very proud of these and the ones that will be coming. As I said, we have been very, very supported, and recently from Francis Collins, he publicly made a statement that he wanted to provide huge thanks to our team, what Simit and Procter has accomplished. And this has been viewed so successfully that the NIH is starting to look at it, whether a model like this would be valuable to think about other NIH grants that have more, not only dollars, but expertise supporting the grantees, as well as different milestones that need to be hit along the way to make sure that the company and the project is indeed moving along at a speed. For those in the audience who've been involved in NIH grants, you know that you get, you go through that incredible process and then you get your grant, and it's often quite a while before you have to share your success or your failures. And this model has been really phenomenal in identifying challenge points. And yes, we have had to, quote unquote, kill a few projects along the way. But mostly what we've been able to do is take projects that have had some challenges along the way and really provide them with the resources and the expertise to help them be successful right from the beginning. And it's been quite successful. And I would say it poises us very, very well for the future. Hopefully there won't be another pandemic in the near future, but I think a lot of these technologies are well positioned to be at the ready for the future. So I know if Steve was giving the presentation, he would have some additional words to say. And I just want to close by bringing this full circle around to my presentation in the morning, which was really focused around, you build the tests, but the country really needs the infrastructure to deploy the tests. And we have now started a partnership with the Rockefeller Foundation, as well as the Bill and that should say Melinda, not Melissa, Melinda Gates Foundation, so that we can all work together to get tests out to underserved communities and all of the schools and the businesses that really need testing to stay and to keep open. Short and sweet, Colin.
Nancy, that was wonderful. Thank you very much. It's very inspirational. And it's been a tremendous amount of work. I can attest to that. And to watch the teams all come together and to really make it, I think, a huge impact, both in the US and we anticipate also globally. We have a few questions that came up during your talk. First is, where can we see the sensitivity and specificity results for the phase 2 diagnostic test from RADx?
Okay, so any of the EUA authorized tests are on, first of all, you can go to the POCTRN, POCTRN.org website, or the NIH RADx website, and it lists the phase 2 projects. You can go to the FDA EUA approved, and you can see the sensitivity and specificity. One of the things that I would like to say is that one of the core foundational elements of this project is that we did our own verification. So the ACME team took every single test, or at least oversaw every single test, verification of the sensitivity, specificity, LOD, so that we confirmed the accuracy of the tests. And we're very encouraged that the tests that are coming out now are definitely more sensitive and more accurate than the earlier tests that came out way in the early days. And now a number of the tests, to get your EUA, it's essentially more of a lab-based process, and a lot of our tests are now moving into community-based clinical studies to verify that we're getting the same type of sensitivity and specificity in real-life, day-to-day use.
Mm-hmm. And that's really important, given the stumbles early on with the CDC test and Abbott, of course, their rapid testing as well. So. And we have another question, this is the final question. Are there any plans for another go at things as the disease mutates and changes to existing tests are needed, such as additional primary probe sets, different antibodies, that sort of thing?
Yeah, thanks. So a number of our tests that were approved were specifically focused on being able to adapt and adjust based on mutations that are coming forth. So that very much pleased us. Not all of the tests, but a number of the tests actually really had the foresight to build into their platform the ability to adjust the inherent, either whether it was using antibodies or markers, that they would be able to easily tweak them based on any permutations. A number of the tests are also multiplex tests, so that now that we're entering flu season, you know, as a clinician, if I have to send a patient one place to get a COVID test and another place to get a flu test, that's a total disaster. So multiplex tests, now that we're heading into flu season, are really, really important. And then a number of the platforms, as were highlighted today, are novel platforms that even a new virus could easily be, the platform could easily be adjusted to accommodate a brand new virus. So hopefully we won't ever have to do this again, starting with a pandemic without adequate testing.
Right. So actually, there's more questions that's popped up. We have a little more time, so I want to make sure we get to them. So as COVID is a pandemic, should diagnostic approaches be focused only on first world, or should third world needs, such as the power requirements, you know, supply chain, that kind of thing, communication infrastructure, be considered as well? Or is that sort of wrapped into the whole thinking in the RADx program?
Right. So, our philosophy was to make these tests available broadly. As you can see at my very last slide was the Bill and Melinda Gates Foundation that is very much focused on international and third world countries. One arm of RADx, so I'm representing RADx Tech. There's an arm of RADx called RADx Up, underprivileged communities, which is focusing on getting testing out to underprivileged communities. And our tests really span the spectrum of higher cost and as low cost as possible. So any of us involved is definitely committed to helping the pandemic worldwide.
So this would be the last question. It's from Achilles, actually. If you were to choose the most challenging aspect or stage that a new test needs to clear to make it to the market in a successful way, what would you choose from your experience with so many companies? Now you can't be a winner, you know, you can't do that.
I'm gonna pull out my hair. So I'm going to answer with one, but let me tell you, there's no one. So I would say many of the companies were very much challenged. The science made sense, but turning the science into reality so you could produce a testing device that was replicable and had consistent performance was very, very challenging, which is terrible, but in many respects, if we're talking about the government money, good, because we were able to eliminate those tests relatively early on in the process. We gave them science, we gave them help, we gave them everything we could give them, but if they couldn't get past that hurdle, not millions and millions of dollars were spent on that infrastructure. And I'd be happy to share offline all the other challenges the companies found.
That's great. And all the data generated, like Acme, the verification results, all that's available at the Radix website or the Acme, the test results.
No, because we have to be careful about confidentiality. The only published data is the data that ended up getting to the FDA for their EUA.
Okay. All right. Great. Thank you. All right. Well, that ends our session, our symposium. I want to thank all the speakers for their time and effort, the stellar talks, very thought-provoking, great questions from the audience. For those who stuck it out, it's been a long day. Maybe for folks over in Europe, it's been into the evening now. But it's been a tremendous opportunity and tremendous, I thoroughly enjoyed it. So Metin, do you want to have some final words?
I also appreciate our fantastic speakers for highly inspiring and instructional the presentation. Many thanks, Colin, for the chairing the symposium. And we are going to have another exciting symposium on tracing, and will be chaired by the Professor Paolo Bonato of Harvard, and look forward to seeing you tomorrow at 10 a.m. the EST, Eastern the time, and you will be receiving the URL and the passcode to connection. Thank you so much. Have a good day. Thank you.
Thank you. Bye, everyone.